The bigger duct is the right anterior and the smaller one is the right posterior duct. With the aid of a spyglass, we were able to cannulate this duct, initially with a Terimo and then with a Visiglide. But the problem was we were not able to achieve a stable access. So despite our multiple attempts at putting the wire in, probing it in, we were not able to get in completely so that we could achieve a complete stable access. And because of multiple attempts also, we eventually faced that most our guide wires also started sharing up. So this was a problem that we were not able to get in comfortably to use any other accessory. So as you can see that there was a frequent looping of these guide wires and we were not able to put the wire sufficiently inside, and hence our further plan of putting in a balloon dilator for dilating this duct was not possible. So eventually we called in our IR team and decided to go in through the PTBD route. Through the PTBD, a good access of the selective right posterior duct was achieved. Here you can see the PTBD catheter in situ. Now we plan to use a spyglass cholangoscope to pulverize these stones. The diameter of a spyglass is around 10.5 French. So we had to initially dilate this PTBD tract, and we dilated this PTBD by up to 12 French. And now through this dilated PTBD tract, we put on a spyglass cholangoscope, and through this we were able to get in quite easily. And once we were inside, these stones were visualized, and we started pulverizing these stones using the conventional laser lithotripter with an energy setting of 2000 megajoules. The problem here was that maintaining a stable access was relatively difficult because orienting the spyglass through the PTBD catheter through the conventional laser lithotripter is slightly difficult, but we had a very good IR team which helped us in this exercise, and we were able to pulverize all the stones that were present in the right posterior duct. So after all these stones were pulverized, next we intended to get in and remove these stone fragments. So initially we tried to put in the guide wire through the PTBD route, through the antegrade route. But again, because of this acute angulation, the guide wire could not be negotiated through the antegrade channel. So we could not get in the guide wire through the antegrade because of the acute angulation. Hence we again used our ERCP scope and went retrograde. Now because these stones had pulverized and they had come out, this wire was now able to negotiate quite easily into the right posterior duct. This wire was then grasped with a pediatric foreign body forceps, which was put in through the PTBD catheter, and this wire was then brought out. And now we had a seamless access of the wire through which a sufficient and necessary traction could be given, so that now we could use any further accessories. And over this wire, now we passed in a stone retrieval balloon, and we were able to remove all the stone fragments. And a complete ductal clearance of the right posterior duct was eventually achieved through this technique. A CBD stent was placed, and the PTBD catheter was removed. But as soon as we removed the PTBD catheter, a small streak of air was seen. The patient, though, was not very symptomatic. She was admitted, kept nil orally for 24 hours and given IV fluids and antibiotics. There was mild pain with no fever. A CT revealed a small collection. A percutaneous drain was placed. Post-operative, there was a slight elevation of the liver function tests, and there was mild leukocytosis. However, after the PCD was placed, patient showed progressive recovery, and by day 4, the reports had normalized, and patient was discharged on day 4. Thank you so much.
Why were the stones not removed through the PTBD
Yeah,
site?
so that was the plan. We'd asked our IR team. Our IR team was very experienced. We'd asked them if they had any accessory to get those stones out through the PTBD catheter. But they said they don't have any such accessory to get those stones out through. See, putting in a balloon through the PTBD would not have given that much of a traction to bring those stones out. So they did not have any accessory, and they wanted us to go through the normal ERCP route and use our balloon. and get it out. So we created a wire which had a sufficient traction, and then that could be brought out. Otherwise, these stones, if you see the opening of the right posterior duct, it was very narrow. So we needed something which had adequate traction through which we could get all these stones out.
Two quick questions. One, could you have used spyglass basket for percutaneous removal of stones? And second is that what would be the natural history if you leave these stones in the right posterior segment alone?
Yeah, so sir, we didn't have a spyglass basket at that point of time, so we could not use that. The second, the natural history is that most of these patients with hepaticolithiasis eventually can have episodes of cholangitis with episodes of atrophy of the involved lobe, and there is also a high risk of developing of cholangiocarcinoma in these cases.
What do you think is the cause of the intraductal calculi?
So it is extremely common in the Far East. There, Clonorchis sinensis is known to be a risk factor. In India, it is not that common though. Finding out the exact cause obviously was not possible in this case.
Can I ask a question?
From the floor?
Yeah, can I ask one question, please?
Please go ahead.
Yeah,
Hi, sir.
nice presentation, yeah. Only one thing. You have dilated the tract up to 12 French. So why did you remove it? Why did you not put and drain in that duct for some time to let the tract form? You would have avoided the complication.
Yeah, I agree with you, but as soon as we placed in the stent, in the initial fluoroscopy, there was absolutely nothing. So we were relatively convinced that it was a safe procedure. The patient also wanted to go home as early as possible because we were told that we'd get it out through the ERCP. So we removed it, though the complication was not very major. She just had minimal symptoms, and I think, yes, that was an option, but we...
Yeah, but 12 French, I think, is always risky.
Dr. Sri, we will move on to the next presentation by
Thank
Dr.
you,
Mandar from Pune.
Good morning, everybody. My case is also about laser, but I decided to show this case because during performing this procedure, I was really stuck at one particular point, and I really had to do some lateral thinking. Fortunately, I was successful in that, and I could avoid a major complication. So, my patient was a 50 years old female patient with obstructive jaundice due to impacted large CBD calculus in the mid CBD. The patient had undergone ERCP at outside hospital, but since the stone was of larger size, the endoscopist couldn't remove the stone, and he had just put a stent for biliary drainage, and the patient was referred to me for further management. Since we don't have a spyglass cholangioscope, my plan was to go for mechanical lithotripsy. So as you can see here, in the MRCP, you can see a dilated CBD with a single large stone stuck at the lower CBD. So when I went inside, I could see the previously placed CBD stent. The stent was removed, and the CBD was recannulated. After the CBD recannulation, I took a cholangiogram. On cholangiogram, I could see, as you can see in this diagram, a widely dilated CBD with a single large stone stuck in the mid CBD. Since the stone was of very large size, I decided to go for balloon sphincteroplasty. And after doing a generous balloon sphincteroplasty, I used a new mechanical lithotripter, and I passed the lithotripter inside the basket, inside the CBD. Since the CBD was nicely dilated and the stone was also of round shape, I could easily catch the stone in my lithotripsy basket, as you can see here. Then I started doing mechanical lithotripsy. Normally, during mechanical lithotripsy, this metal sheath advances and it will crush the stone against this metal sheath. But here, instead of the stone getting crushed, my wire got broke. So the wire broke near the handle of the basket. Now I was really in a big dilemma what to do, but as a rescue measure, I decided to use Sohendra lithotripter. So I removed my scope and I passed this metal sheath of the Sohendra lithotripter over the basket wires. As you can see here, it went inside, it nicely went inside and went near the stone. So normally here also, as you go on tightening the handle of the Sohendra lithotripter, slowly this metal sheath advances and it will either crush the stone or it will sever the basket wires, so that at least you are rescued from this situation. But here again, unfortunately, instead of the stone getting crushed, my wire broke again. And this time the wire broke very close to the mouth of the patient. Now I had very limited length of the wire available to repeat the mechanical lithotripsy, Sohendra lithotripsy. So I was really in a soup. I didn't know what to do. So I did multiple attempts to remove the, disengage the stone. I even passed my rat tooth forceps to break the wires mechanically. But all my attempts were in vain. I even tried to pass a balloon or stone extractor balloon or basket by the side of the stone so as to disengage the stone. But since the stone was very large, it was blocking the ampulla completely, and I just couldn't do anything. So this went on for some time, and I was really at my wit's end. So since the procedure went on for some time, we decided to just put a stent temporarily and buy time and try our luck the next day. But even on the next day, my options were very limited. One of the options was to send the patient for surgery. But when I was trying to disengage the stone, I could see that the end of the stone was projecting at the ampulla through the basket wires, like this. So I decided to use a laser. So I got laser from our urology unit. The holmium laser was used. The laser beam was passed through our ERCP cannula, and the stone was pulverized using this laser. The moment the stone was broken, my wires got disengaged, and I could easily remove the wire. I passed a biliary balloon, and remaining stone fragments were cleared completely. And when I was sure of the complete clearance of the CBD, I just put another biliary stent. Both the stents were placed in situ for a period of about 3 weeks. After 3 weeks, I removed the stent. The check cholangiogram was done. It showed complete clearance of the CBD, and the patient went home very well. So as a conclusion, I would like to say that one cannot trust mechanical lithotripsy in every case of large CBD stones, and backup of spyglass cholangioscope is necessary, particularly when you are trying to deal with large CBD stones. And most importantly, in endoscopy, innovative approach helps in tackling difficult situations like I did. Thank you.
Thank you, Dr. Mandar. A good rescue procedure for you.
Thank you, sir.
If I saw the last MRCP clearly, there was still some stones.
No, sir. My video got back. So.
Okay. Fine. Yes.
Very unfortunate that both the time your lithotripsy did not work. Despite, is there any technical problem you had? Because both the lithotripsy are not working.
Yes, sir. I just thought about it. So normally, Sohendra we use when you are using a normal basket. Here I was using a mechanical lithotripsy basket. Maybe the wires in the shaft are not that strong. That is my conclusion, or that is my guess. Because of that,
these were indigenous products, or they were?
No, sir. It was Olympus lithocrush basket.
Tell me one thing, which not clear is that your laser fiber went through what?
Through our simple ERCP cannula.
So it went through the cannula?
Cannula, yes, sir.
My question is, the first MRCP picture, was there a stricture just below the stone and we failed to dilate that stricture or something?
No, sir, it was, there was no stricture, and actually before trying to remove the stent, I went inside, I did generous balloon sphincteroplasty. Then only I went inside.
You know, one question, India is a very health conscious economy conscious country.
Yes, sir.
How does the cost that you incur through all these procedures, how does it compare with surgery, which is, especially when you get into problems
Sir,
like this?
actually, sir, in my practice, up to about 19-20 millimeter stones, we can remove by using mechanical lithotripsy. So for that size of stones, surgery is not really necessary. If the stone size is bigger and if you want to use spyglass and other laser, then the cost really escalates. In that case, you can consider surgery. But if the stone size is up to 20 mm, I think ERCP with mechanical lithotripsy definitely works better. And the cost is considerably less than what it is required for surgery.
What Dr. Harshad is saying, after you had complications, could you have handed over to the surgeon? Is that what you're
That's what you want. But sir, that is like, it's a dilemma. The patient was referred to me, then it was my responsibility.
It becomes an issue.
It is difficulty.
Thank you very much, Doctor.
Thank you, sir.
We request Dr. Vikram from Kolkata to present.
A very good morning, everyone. I'm Dr. Vikram from Apollo Multispecialty Hospital, presenting an interesting case of motorized spiral enteroscopy assisted ERCP performed recently.
Enteroscopy assisted ERCP. A 70-year-old gent.
Can we stop the video once? Sorry. A 70-year-old gentleman with a background history of hypertension, gastric diffuse large B-cell lymphoma, post-partial gastrectomy and chemotherapy in 2013, presented with severe upper abdominal pain, jaundice, and pruritus for 1.5 months. He underwent partial gastrectomy with Roux-en-Y gastrojejunostomy. The anatomy is as depicted in the figure. Initial lab parameters showed neutrophilic leukocytosis, raised serum amylase lipase levels, and predominantly obstructive jaundice. Contrast-enhanced CT abdomen done elsewhere showed cholelithiasis, choledocholithiasis with polypoidal growth in the right vesico-ureteric junction of doubtful nature. MRCP showed chronic cholecystitis with suspicious concretion at the cystic duct, dilated common bile duct of 9.2 mm, IHBR, and evidence of choledocholithiasis 1.6 into 0.8 centimeter, elongated and large calculi and distal CBD. A clinical diagnosis of acute mild biliary pancreatitis, cholelithiasis with choledocholithiasis, polypoidal growth in the right vesico-ureteric junction, gastric diffuse large B-cell lymphoma, post-partial gastrectomy and Roux-en-Y gastrojejunostomy and chemotherapy in 2013, and systemic hypertension was made. After taking the informed consent, we proceeded with intubation, followed by novel motorized spiral enteroscopy assisted ERCP via antegrade route under general anesthesia. The anastomotic site was identified. Around 40 to 50 centimeters later, jejunostomy site was seen. Afferent and efferent limbs were identified. Afferent limb, that is a biliopancreatic limb, was then entered, as you can see the bile. Active pleating of the small bowels can be seen. During the procedure, we were instilling water to facilitate the scope progression because water does not allow excessive distension. However, the air distends the bowel and decrease the progression of the scope. Biliary opening was identified. A small periampullary diverticulum was noted. Using 5.5 French tapered tip triple lumen cannula, selective CBD cannulation was done. A gush of bile came out. Cholangiogram then showed oblong-shaped CBD calculi with the biliary dilatation. Splitoplasty done with CRE balloon from 10 to 12 mm. A balloon sweep was then taken and a large calculus with a sludge removed. Few more balloon sweeps were done and concretions removed. A 7 French 7 centimeter double pigtail biliary stent was deployed. He then underwent cystoscopy plus transurethral resection of bladder tumor plus cystodiathermy 2 days later. Biopsy revealed a papillary urothelial carcinoma, non-invasive, low-grade. He then underwent laparoscopic cholecystectomy and was, following 6 weeks, planned for motorized spiral enteroscopy-assisted stent removal and biliary clearance. As we can see, the previously placed CBD stent seen in situ, which was removed using a snare. We tried to remove the stent through the working channel, but it could not. Hence, the whole system was taken out and re-entered. We entered the afferent limb, that is the biliopancreatic limb. Using 5.5 French tapered triple lumen cannula, selective CBD cannulation was done. Cholangiogram revealed filling defects. Splenotoplasty done using CRE balloon up to 9 mm. Multiple balloon sweeps were done and caliculi were removed. To summarize, in surgically altered anatomy, normal ERCP procedure has limited success. Novel motorized spiral enteroscopy assisted ERCP can make the procedure more accessible. Advantages are usage of standard ERCP accessories, stable position, single operator, and shorter duration with a greater success rate. Thank you.
Yeah, a good presentation. And you demonstrated nicely that spirus enteroscopy can also be used, like just like a double balloon or a single balloon in the post-operative setting. And my question is, like spiraling through the, anastomotic limb, does it produce any damage? Has any damage because a spirus enteroscopy has been recorded in literature?
So the spiral enteroscopy, there is an overtube with the fins, the plastic fins, which are traumatic. And in most of the cases, it doesn't cause any trauma to the surgical site, sir.
No, my question is different. Like, like in single balloon, double balloon, it's a linear force that is being, and then the pleating. Yes. Here, you spirally, rotate and then pleat it. The pleating is different here.
Yes, sir.
Right? So, is there any literature, recording that there was some damage?
Sir, I have gone through the literature and recently published the paper of 36, the novel motor spiral enteroscopy assisted ERCP. They found only one complication out of 36 cases, and that was also post splenotomy site bleeding. So there was no any trauma because of it.
That's good.
Dr. Sir, nice presentation.
Thank you, sir.
So thrice you had to do the spirus enteroscopy. First to remove the stone. And how come the stone again reappeared probably after cholecystectomy?
So first, when we entered, that time, it was only one time when we entered, sir, first time. During the follow-up, because the stent was not able to come through the working channel, we had to bring out the whole system and go inside.
And third time again, for balloon sweeping, you have to do third time also.
Yes, sir. That was during follow-up, sir.
During follow-up. Three times you have to do a spirus. How come the stone reappeared? Because you already cleared the CBD.
Yes, sir. We cleared it possibly because of the duration of around 6 to 8 weeks. Possibly there could be some concretion which was left behind. That's the reason we put a stent there.
But that's a big stone. Second time what you removed it. Cannot
Yes,
be just probably what we see nowadays is many times when the gallbladder surgery is little complicated, they squeeze the gallbladder, some stone may slip into the common bile duct. So we always make a point when we are removing the stent, we always sweep the common bile duct. Now my basic question is, you have to do 3 times spirus enteroscopy, nicely demonstrated. You were lucky in the post-operative period after the bypass surgery and other thing, you didn't have additions, so you could do that. Did you think of alternative like laparoscopy, cholecystectomy with a CBD exploration? One go.
Possibly not, sir, because of the involved risk and the complications. So possibly laparoscopic CBD exploration has more side effects, more complications.
The best of centers also?
So according to literature.
Anyway, nice presentation. I congratulate you. Thank you.
I have one. Can I ask a small question? Do we have time?
Chalapati Rao.
Good morning, everybody. I thank the organizers for giving me this opportunity. So, title of my presentation is Retrieval of Retained Pancreatic Stent Fragments. So we had a young alcoholic patient who had repeated attacks of pain abdomen, and now recently he had breathlessness and chest pain. He looked to be ill-nourished. He had tachycardia and tachypnea. Abdominal examination showed mild epigastric tenderness, and there were reduced breath sounds on both lung bases. So chest X-ray showed massive left-sided pleural effusion, and further CT scan abdomen showed calcifications in the pancreatic duct with evidence of ductal disruption at the distal body level, and it's causing bilateral pleural effusion, more on left side. Pleural fluid amylase on tapping showed 45,000 units per ml, and intercostal tube drainage was placed on the left side, and then it is drained. So these are the representative CT images. And then we went ahead with ERCP with an intent to actually bridge this disruption. And on pancreatogram, you can see that there is evidence of small collection, which is actually communicating towards the mediastinum. And we left a long stent, 5 French into 10 centimeters long single pigtail stent. So after improvement, patient was discharged but lost to follow-up. He stopped alcohol, but again he came back in 1 year with dull aching pain. There is resolution of pleural effusion on chest X-ray, but stent was noted to be actually in situ, but with fragmentation. So we went ahead with the ERCP with an intent to remove these stent fragments. So we dilated the papilla, the pancreatic sphincter up to 6 mm, and after 6 mm balloon. And after that, we used the standard Domia basket over the guide wire. And then we could actually, with multiple attempts, we could grasp this stent, which is actually retained in the downstream of the pancreatic duct, that is closer to the ampulla. And then we could able to retrieve this, and then left at the ampulla, and then we grasped it with the rat tooth forceps, and then this fragment of stent was retrieved. But the one which is distal to that is upstream, we are not able to retrieve with the same technique, so we had to use a spyglass pancreatoscope this time. So we went ahead over the guide wire cannulation of the pancreatoscope, and then under the fluoroscopy and direct vision, we actually started loading it over the guide wire. And as we progressed distally, we could see that stent fragment, which is actually lodged in somewhere in the distal body and tail region. So after identifying this, we had removed this guide wire, and we are debating which accessory to use. So fortunately, we had that spy snare with us, and we decided to go ahead with spy snare. So after multiple attempts and manipulation, we have opened the spy snare over the wire, and then we gradually could grasp it. But my assistant was a little bit over enthusiastic, so he actually, in the middle of the procedure, we identified that the stent fragment actually got crushed. So it was divided into two, transected with this snare, and then whatever we could retrieve, we had retrieved with that attempt. So after retrieval of this fragment, we again chased the third fragment, which was actually transected during the procedure. Again went over the guide wire and reached the distal body and tail region. And again we saw this fragment. So this time we wanted to see how we could grasp it with the SpyBite Max forceps. But with multiple attempts, we are not able to actually hold it, but we could not retrieve it because there is a little bit of impaction of this stent in the deeper parenchyma. So we tried with this, it didn't work. So again, we used the same spy snare, and we actually manipulated it. Again, we could grasp it, and this time we were careful not to apply a lot of pressure. And with multiple jiggling movements, we could disimpact this stent from the parenchyma, and slowly we could withdraw it. So the total procedure time took about, I think, 45 minutes for this second attempt of ERCP. The procedure was done under general anesthesia with the patient under prone position. And with this attempt, we could finally clear the entire pancreatic duct, and the remnants were cleared off. So these are the retrieved pancreatic stent fragments. And then at the end, we had to again put a new PD stent to avoid any risk of pancreatitis. So during this pancreatoscopy, we did not identify any stones in the as such main pancreatic duct. So probably the initial CT, what was shown, probably these stone fragments were there in the side branches. So patient improved uneventfully. After 2 weeks, we had to remove this stent, and patient remained asymptomatic 6 months on follow-up. So retrieval of these fragments from the MPD is very challenging. We have many tools like forceps, Domia basket. Sorry. I have 1 more minute. So can you please load it? So we have many tools and accessories like forceps, Domia basket. We have seen a few cases in the live session also. Yeah, so the last slide, please. Yeah, okay, yeah. So, and it sometimes helps, especially with the fragments which are closer to the ampulla, but which are very distal upstream in the duct. Pancreatoscopy is actually a useful tool, which allows a direct visualization of any pathology in the MPD and stent fragments. It allows a guided retrieval of the stent fragments. We have SpyBite Max forceps which can help, but here we could get away with spy snare. Thank you for your patient listening.
Thanks for a good presentation. You were very lucky because there were no calculi downstream. In that case, then you'd have spent more time probably pulverizing those before retrieving the stent.
True.
And like the technique that you showed is good because we pass the snare beyond and try to grab from the top, that is a distal most stent, rather than holding it proximally and trying to pull.
Yeah. And there is no stricture as well. We are lucky.
I missed it. Did you dilate the ampulla before starting?
Yeah, 6 mm balloon. Yeah.
So, in every case, you think pancreatoscopy can be done because the diameter of pancreatoscope is 10 French. So, do you think that's a limitation? Because stent being placed there, the duct will not be dilated in all cases.
True. So in not every case it is possible, sir. Sometimes PD is very thin. We can't pass every time, especially to reach the duct which is quite upstream. It's very difficult.
Do you think that the distal end was impacted in the side branch or somewhere?
Yeah, a little bit. Yes, sir. Yeah.
Dr. Rao, nice presentation.
Thank you, sir.
And yesterday you saw that how much we are struggling. But your video was top class, and I appreciate it. And thrice you had to do a spy scope. Other next alternate would be surgery. That's worth attempting this. What was there was no stricture and dilated. Why the reason for the stenting?
So the initial stenting, the second stent.
Initial stenting.
Initial stenting, he had a internal fistula, pancreaticopleural fistula.
Sorry,
so
I missed
for
out
that, yeah,
that.
yeah.
And you said it is embedded in the parenchyma.
Or a side branch, sir. We couldn't go till that extent. So probably it must be.
Yeah. Maybe side branch.
Maybe side branch, yeah.
Congratulations.
Thank you.
Charapati, one last question.
Yes.
The first time you placed a stent, was it a single pigtail stent? Why did it?
Yeah, it's a single pigtail stent. So it got, because he lost to follow, probably that pigtail end in the duodenal and pigtail part of the duodenal end must have got dislodged and it got broken. Okay. So 2 fragments were retained in the duct.
Okay, thank you.
Thank you.
Presentation from Dr. Akash from Chandigarh.
Good morning, respected faculty and dear colleagues. I bring greetings from PGI Chandigarh. I'll be presenting a case of ampullary adenoma with intraductal extension. So these are precancerous lesions arising in and around the duodenal papilla. They can be either sporadic or may be associated with familial adenomatous polyposis syndrome. They're often asymptomatic, but they may present with cholangitis or pancreatitis. So we had a case of 70-year-old female who was a known case of hypertension for past 10 years. She had an old history of CVA, a prior carotid endarterectomy, and she was on antiplatelets. She had a past history of ERCP and stenting for gallstone disease and cholecystectomy, followed by cholecystectomy in 2016. And this time around, she presented to us with history of pain abdomen, and she was evaluated outside and found to have a distal CBD stiction features of extrahepatic biliary obstruction. So we took the patient up for an endoscopic ultrasound and found a dilated CBD along with intrahepatic biliary radical dilatation. And what we could see next is that there was an ampullary mass, and there was an intraductal extension as shown in the figure, which was around 8 mm. So we took a surgical consult, and the options were ampulectomy versus Whipple's, but because of the high-risk candidacy and we took an informed consent, patient refused the surgery. She was a frail lady. So we planned for an endoscopic ampulectomy. So this was an endoscopic view of the ampullary adenoma. So we took the patient up for a snare ampulectomy. We used a 25 mm oval snare with an endocut mode. And we tried to remove the tumor in an en bloc fashion. However, we could not do it in the one go. So we removed it in a piecemeal fashion. We then identified the PD opening and put in a PD stent so as to prevent any risk of pancreatitis. So we followed up the patient after a few days, and we took biopsies from the lateral aspect to see any lateral extension of the tumor, and we found that there was a lateral extension, which was then taken care by a session of organ plasma coagulation as shown in the video. So for the intraductal part, we then went ahead and decided to do a RFA for the intraductal extension. However, we could not achieve the coagulated necrosis and the whitening of the tissue on 2 occasions. And we took the samples as shown from the on the left side, and we found that there was a viable tissue left even after the 2 sessions of RFA. So we cut open the CBD, we did a sphincterotomy, and then we decided to use a balloon so as to we snugly fit the balloon beyond the tumor, and we pulled it out so as the intraductal part becomes extraductal, and this extraductal part was then removed using a snare in a piecemeal fashion. So since we had a failure of RFA, we had to use something. So we used the balloon to bring the intraductal part and make it extraductal. So you can see the intraductal part is now extraductal, and now it has been removed with the snare. So we could achieve most of the intraductal part was removed. As you can see, some of the part was left in the lateral side, as you can see before and the after pictures. So this lateral part was then taken care by the second session of organ plasma coagulation. So we coagulated the borders, we coagulated the lateral aspect. And all the time the PD stent was in situ to prevent any risk of post-procedure pancreatitis. So patient tolerated the procedure well. There was minimal pain. There was no evidence of any pancreatitis. She was conservatively managed. She is 2 months post-procedure now. Her LFTs have normalized, and she is now scheduled for a repeat side view endoscopy. Thank you.
Good job, like in a inoperable patient.
Yes.
Just wanted to ask you a doubt. Did you say RFA first?
Yes, sir.
You also used RFA?
On 2 occasions, sir. We did RFA on 2 occasions for the intraductal part. However, we could not achieve the coagulated necrosis of the tissue. So the sample was biopsied. There was a viable tissue. So then we decided to use the balloon to bring the intraductal part and make it extraductal and then remove it with a snare.
Yes. It's a nice presentation, but this much of extension, people should not go with the idea that Whipple is the best option, actually,
Yes,
but since you could not do that, what was the histopathology I missed out?
Sir, it was tubulous villus adenoma with high-grade dysplasia.
Okay, so, and you have to do in 2-3 sittings, no?
Yes, sir. We did 2 RFA sittings and one the snare ampulectomy, and now she's planned for. We did 2 sessions.
Check MRCP or US to find out anything left out there in the intraduct?
So she's planned for a EUS and a side view endoscopy now, but she couldn't follow up for some personal reasons, but she'll be following us with us in a few weeks from now.
And I missed out how old the patient was?
70-year-old.
70 years. So there's no other option that you have to do.
Yes, sir. The surgery was high risk because of the prior history of endarterectomy. She was on antiplatelets, and the performance status was also not very good.
And you could not do the PD cannulation prior to ampulectomy?
No, we did it after we removed the ampullary tumor. We stented the PD.
Excellent presentation.
Thank
Can I ask you a question? My question is, in the first attempt, why was an attempt not made to remove the intraductal part? 2, is there a role for any surgical procedure like a duodenectomy and an excision rather than a Whipple's in this kind of a case? 3, what is the long-term effect of so much of laser coagulation once you remove the PD? Is there a risk of stenosis at the mouth?
So for the first part, sir, For the first time, as already the guidelines have recommended that the intraductal extension should be managed with the RFA or a photodermal therapy if it is not more than 2 centimeter extension. So it was a 8 mm extension. So we tried the RFA first, however, we could not achieve what we attempted. That's why we had to revert to this time. And obviously surgery is an option in these cases, but because she was a frail lady and a 70-year-old and had multiple comorbidities, so we decided to do this endoscopically. And the follow-up is she's 2 months into the post-procedure. She's now, the studies have shown the 70 to 80% necrosis with the RFA. However, we could not achieve that. But as you can see, we tried to remove all the intraductal part, and she's now being planned for an repeat EUS and a follow-up side-view endoscopy to see if there is any residual tumor. And we left the PD stent in C2 so that there is, because of the APC, and if there is any residual stenosis, but we did not place a biliary stent because post-procedure she did not had any pain, and the LFT is also normalized.
Akash, but correct me if I'm wrong, but isn't an intraductal extension a contraindication for ampulectomy?
No, sir.
In fact, we heard it even in the lectures that were preceded yesterday and day first today, that once there is an intraductal extension of a tumor, periampullary tumor, it's a contraindication for ampulectomy.
So if it is more than 2 centimeters, I think then it's a contraindication, but if it is less than 2 centimeters, I think you still go ahead with the surgery. Thank you, sir.
We will take just 2 to 3 minutes to announce the result.
I think we should congratulate all the presenters. They did a good job. But one thing, there was a dress code. Some of you missed the dress code. So, people who really followed the dress code had little more marks. But the marking was not too much for the dress code, but still.
What is the dress code expected? Regional.
Traditional Indian style of dressing, yes.
Oh, that has been mentioned earlier. I think this is a very nice way of projecting your work for the benefit of others. Key is the documentation. All of you should have the best documentation possible in your unit. You will never know when you will be doing a great work, but you don't do the documentation, then will be. And the documentation should be 24/7. You never know when the odd case will come and an emergency case will come. That time will be searching for the documentation. I know in the hall many of you would be doing as much as this work being done now shown here, but people had documentation. And another thing is, immediately you edit it and keep it ready. There are several conferences happening. And the best one I've seen is in DDW, Best of World Cup also. You can also, and from India, many people have represented, got the prizes also. So you all should be geared up for the documentation, the key. And there is a PPT available how to do the documentation. Please go through that.
Now I think we are all waiting for the results. So we'll request Dr. Mahesh Goenka to announce. Yeah.
As I mentioned, that there were 4 criteria: novelty of the case, the quality of presentation, the question-answer session, and a small prize for dress code. That was a small component. So we have 3 winners. The second and the third prize is being shared because they got equal marks. And the second and the third prize goes to Dr. Srihari from Delhi and Dr. Chalapati Rao from Vizag. They would get their prize from Boston Scientific at their place, which will be a bundle of accessories. So congratulations, Dr. Chalapati Rao and Dr. Srihari. The others also did well, but the first prize goes to Dr. Vikram from Kolkata. Congratulations, Vikram. I must congratulate all the presenters who are very good and they stick to their time. That's very, very, very nice. Thank you very much. And thanks to the co-judges.
I thank all the judges and congratulate all the winners, and all were very interesting and learning videos for all of us. So now we are moving on to the next session of ERCP lectures, and I would like to invite Master of Ceremonies for this session, Dr. V.G. Mohan Prasad, Dr. K.K. Rawal, and Dr. Chalupati Rao. I would like to invite all the chairpersons for the session, Dr. Shiran Shetty, Dr. Ramesh Kumar, Dr. Rakesh Patel, Dr. Praveen Rathi, Dr. Vishal Bothara, Dr. Karan Julka. I request chairpersons to invite speakers on the dais.
Yeah, hi friends. We're going for video lectures of ERCP. The first speaker will be Dr. Amol Bapai, and the chairpersons are of course Shiran and Ramesh Kumar, Rakesh Patel, Praveen Rathi and Vishal and Karan Julka. So the topic Amol Bapai is going to speak is endoscopic stenting for pancreatic ductal strictures. When, which, what size, what length, and what duration. And very important for all of us. Over to Amol.
Good morning, and thank you, Dr. VGM, for this introduction. Thanks to Dr. Amit for this invitation and honor. So stents for pancreatic duct strictures, when, which, how long, which stents, all that. So let's look at some of these points. So chronic pancreatitis, we know, comes in various forms and shapes and sizes, as we might say. But strictures do form a predominant section of the chronic pancreatitis patients. And we're going to discuss stents in this condition because we use stents for even other conditions. We'll come to that, but we'll focus on this particularly. So let us spend a minute to look at what are the characteristics of strictures in chronic pancreatitis. They differ according to the location, whether they are in the head, neck, body, or tail, number of strictures, the etiology, benign or malignant, and dominant versus non-dominant. And it's important to note that 2% of newly diagnosed chronic pancreatitis may harbor cancer. So that is something which is very important to remember. When do we stent for pancreatic duct strictures? When there is a dominant main pancreatic duct stricture and when patients have pain as the predominant symptom. So pain is the only indication when we are actually going to stent these patients. Stenting has not been shown to be effective for treatment of malabsorption or diabetes. And we should technically be stenting only after we've ruled out malignancy, after imaging or breast cytology or pancreatoscopy, EUS, whatever we might choose to do. So how do we define a dominant stricture? At least one of these following characteristics have to be present. Upstream MPD dilatation of 6 millimeters or more, or prevention of contrast medium outflow alongside the 6-French catheter inserted upstream from the stricture, or this third one, I don't think any one of us use in clinical practice, but abdominal pain during continuous infusion of nasopancreatic catheter inserted upstream with 1 liter of saline. I don't think we're going to be doing that, but I think the first two criteria are important to define a dominant stricture. So what is the philosophy of stenting in these patients? As I mentioned, dominant stricture with pain. And what we are aiming to do is aiming to do a continuous dilatation of stricture with sequential stents, and we may even choose to use multiple stents to achieve a maximum diameter. We can also use fully covered stents, we'll come to that. Usually a prophylactic stent exchange rather than an on-demand exchange has been recommended, although there is some controversy regarding that nowadays. And recognizing stent-induced complications early and the end point of treatment should be complete resolution of the stricture and not just pain relief. Very often. When do we stent? So painful dominant MPD strictures is the primary indication, but in patients with recurrent acute pancreatitis or chronic pancreatitis after excluding metabolic causes and patient having a pancreatitism, this becomes another indication where we use stents more frequently. And ductal disruption in the setting of chronic pancreatitis also demands stent placement. These are some of the other indications which we are not going to be touching upon today. So what is the objective of stenting? Decompression of the main pancreatic duct, which relieves the pain. That is the hypothesis. And the response is seen immediately in 65 to 95% patients and up to 2 to 12 years. And after 12 years, the effect is about for 58% patients. And continuous dilatation of the stricture. Also, when we have stones and strictures both, facilitating the stone clearance after ESWL is also done by the stent placement and also for treatment of pancreatitism. And technical success is defined as bypassing the dominant stricture, and which is associated with a 3 to 10% technical failure rate because of either a failed cannulation, tight stricture, or a stone or an altered anatomy. So how do we stent? So we've seen this yesterday and day before in all the live cases, but some basic principles one can with or without a pancreatic papillotomy. So although most of us would perform a pancreatic sphincterotomy, it is not mandated to do that. So sometimes you may choose not to do that either. There are various thoughts as to how the stricture should be dilated before placing the stents. So we can use either a balloon, either a CRE or a hurricane balloon, a bougie Sohendra dilator, 5 French or 7 French Sohendra stent retrievers, or even 6 French cystotomes have been described. And dilatation alone is not effective. PD strictures are resilient, so it has to be followed up with a stent, because without that, it's not possible to be, the strictures are going to come back. So this is how we place the stent. So which stent now? So there are a variety of options of pancreatic stents. Some common features are pancreatic stents should have multiple side holes. They should have some anti-migratory property in form of either a pigtail or a flap. And negotiation of the stricture should be possible, so one may choose to use a tapered stent or a straight stent. And there are several variations that are available in terms of straight or pigtail, straight tapered, several sizes, special shapes, and the material also differs, polyurethane, PTFE or others. And there are also stents with other flap designs and without side holes. How do we choose the correct stent? So as I mentioned, variety of stents are available, but some general principles, we need multiple side holes. In a non-dilated pancreatic duct, do not use a stent with internal flaps because the flap can irritate the lining of the duct. In tight strictures, we tend to use tapered tip stents. In tight strictures, we tend to use stents with an external flap also. But if the stricture is loose, probably a single pigtail stent is better, preferable to a just a flap stent, because it's more likely to migrate. Although we've seen that if a pigtail stent migrates inwards, then we can be really in big trouble. And angulated anatomy or pre-curved, this is the situation where pre-curved or special design stents may be required. So basically 3 companies which are making these stents, and these are some of the comparisons. I won't spend too much time on this, but variety of stents are also available from some other companies, but one has to choose the stent accordingly. So the ESG recommends that the stent size, a single large caliber 10 French stent or multiple small caliber stents side by side. At least the stent should be at least as large as the PD diameter and should not exceed the size or the diameter of the normal downstream duct. So what it means that if the duct is not too dilated in the head and the neck region and there's a stricture in the neck region, do not try to put in a 10 French stent at that point in time, because that could induce pain. At the same time, if it is very angulated, sometimes a 10 French stent does not take the curve as well as a 2 7 French stents does. So here we might have to choose multiple or 2 7 French over a 10 French. The stent length should be, of course, long enough to traverse the stricture, and the duration should be an uninterrupted 1 year of treatment if the symptoms improve after the initial drainage. And exchange can be either on demand or routinely every 6 months. There is again, no consensus on this. And the international consensus actually recommends exchange every 2 to 3 months. So outcomes of stent placement, 10 French have shown superior results over smaller stents, and the immediate pain relief is up to 88%, and on-demand stent exchange is becoming more and more favorable now, and the predictors of outcome are short disease duration, low frequency of pain attacks, and obstructing head calculi. So these are some of the outcomes that one has to be careful about, that stricture resolution does not correspond to long-term pain relief. Patient may still continue to have pain because of parenchymal disease, which has to be addressed. Early responders are more likely to maintain long-term benefit, and there is no study which has compared scheduled versus on-demand exchange, and no study which has compared single large versus multiple plastic stents. And these are some of the predictors, as I mentioned. What do we mean by a refractory stricture? Dominant stricture that persists or relapses after a single pancreatic stent for 1 year. And in these situations, as Ivo Boskowski's group has published this, median 3 stents and 74% asymptomatic at 9.5 years post-stent removal with only 7% recurrence rate. Multiple stents, although there is also a controversy that is it really worth it? Because what they've said is 2 stents are not superior to a single stent or a step-up approach. We also use fully covered stents, and conventional fully covered stents have their problems because of migration, de novo stricture. But there is a specific stent design as the bumpy stent from Taewong Medical. This has a flared ends to prevent migration and irregular cell size, which the segmental radial forces, and therefore it gives a bumpy kind of an appearance. This has a lower migration risk and higher stricture resolution, and one can also place a plastic stent over this stent, So this is how the stent is placed. And what is the philosophy? Continuous stricture dilatation by exerting the radial force, which reduces the number of stent exchanges that may be required, and therefore reduces the number of interim procedures. We are still not sure whether it provides a superior stricture resolution. There is no consensus on this, and there's multiple plastic stents versus metal stents. Probably there's no controversy. That's still controversial. So we've seen this. So we can probably skip this video. Just go this. So this has a lasso which can be removed after about 6 months or 1 year. So these are some of the studies which have shown that the bumpy stent usually has a superior good results. An 11-year follow-up study showed that biliary obstruction or de novo strictures did occur, but these are all types of fully covered stents. This is not just the bumpy stents, so that is important. And comparing fully covered stents versus multiple plastic stents, this is a systematic review which has shown no difference in any of the outcomes. So probably outcome-wise, long-term outcome-wise, both these modalities are very similar. A word about biodegradable stents. This expected disintegration time is around 3 to 6 months, but the issues are stent occlusion and disintegration during the balloon sweep, and also unpredictability about the disintegration. That is the problem currently. What do we do when transpapillary drainage fails? EOS-guided pancreatic duct drainage is a way to go, and that's not the topic today, but I just wanted to put a slide on that. A last word about when do we remove pancreatic stents. After the pre-decided duration of about 3, 6, or 12 months, or usually 12 months, the 7 French should be exchanged every 6 to 12 weeks. 10 French can be exchanged every 3 to 6 months. The stricture should have resolved on the pancreatogram, and the contrast should drain after removing all the instruments, including the guide wire, and just observing. And within 5 minutes, if the pancreatic duct drains off, then probably the stricture is resolved. And also make sure that there are no plugs or residual stones or sludge. Restenting may be required in some of these patients, so keep watching these patients, keep them on a close follow-up, because sometimes they may come back with pain or even septic complications. When do we not stent? So in a non-dilated duct or a non-dominant stricture, one should not be stenting. Asymptomatic patients, there is no indication to stent. Multiple strictures, usually more than 2, are usually not going to be amenable for stenting. These patients are better treated with surgery. And distal body and tail strictures, again, are not very amenable for endoscopic stenting. And suspicion of cancer or AIP deserves its own management. And when do we back out? So we should not be persisting with stenting more than 2 years, max up to 3 years if you've seen good clinical response in the initial phase. And do not persist, particularly if there is no progress in the stricture opening up, no pain relief, and upsizing of stents is not possible, and even when the patient is non-compliant or when the follow-up is irregular, because stents, indwelling stents in a not following up patient can be a disaster. So this is just an algorithm. Rule out autoimmune pancreatitis, rule out cancer, and then if there is a benign stricture, if it's stone disease, first treat the stones, and if there is no stones, then treat the stricture as per what we discussed. So a few key takeaways: select the correct patient for endotherapy, rule out cancer or autoimmune pancreatitis, ESWL for associated stones. Single 10 French stents is usually the way to go for 1 year, multiple side holes, on-demand or scheduled exchanges, stent-free trials and responders. Refractory strictures can be treated with multiple plastic stents or fully covered stents or surgery, and failed transpapillary drainage would require an EOS-guided approach. Everybody is invited in July at Pune for this third space course. Thank you so much.
Thank you, Amol, for excellent presentation. We'll take on just 1 or 2 questions now.
Amol, can be pest for even 3 to 6 months. So what are the risk of side branch blockage by fully covered stents?
See, particularly the bumpy stent, because of its uneven design and that bumpy nature, it is said to allow side branch drainage. So it has not shown to actually dilate the side branches or cause obstruction to the side branches. So that is the beauty of that design of that stent.
Dr. Amol?
Yeah.
So like in the biliary stricture, we commonly come across that we put 3 stent, 4 stent, 5 stent, depending upon the need. How frequently you encountered in the pancreatic stent? Because most of the time I have seen 10 French stent you put, and majority of the time the stricture resolved. Or in your practice, how many times you put 2 or 3 stents? Are you doing that kind of practice?
Yeah, see, we've put up to 3 stents, not more than that.
Commonly?
Not very commonly, I would say about 10 to 15% of the times. 85 to 90% 1 stent. And what is my policy is, if the duct is very angulated, particularly at the neck region, usually, sometimes the 10 French stent is a little bit too stiff to take the curve. In which case, we prefer to put 2 7 French rather than a single 10 French, but that's more because of the anatomy and not the tightness of the stricture.
And another question is, like biliary stricture when come, we put our all effort to find out is it malignant or not. But generally in the pancreatic stricture, we don't do that much of the strict and the stringent workup, because we feel there is a chronic pancreatitis, there is a stricture.
That is
and
true.
Most of the time patient doesn't turn up with the pancreatic malignancy also.
So Rajesh, I think there is the decision is based also on the patient demographics. I think our country, we see so much of chronic pancreatitis in a younger population. Biliary strictures usually occur in the 60+ age group, where cancer is much more common. But chronic pancreatitis, we are seeing patients from 15, 20, 25 age group also, and of course, but if the patients are elderly, if they have a shorter duration of symptoms, then this is the time then we should rule out a cancer, probably by doing an EOS before embarking on the endotherapy. This would be my recommendation. So at least rule out a small tumor on an EOS before embarking on this thing, and probably at least at the index ERCP, get a breast cytology, if not a pancreatoscopy. Because pancreatoscopy in every chronic pancreatitis is definitely not a recommendation. But at least get a breast cytology if it's only one single dominant stricture in an elderly patient with a shorter duration of symptoms.
Sorry, we are running late of time.
Okay, thank you, sir. So now thank you, sir. So we'll move on to the next talk, biodegradable stent in ERCP. Now I invite Dr. Sandeep Laktakia from AAG to deliver his talk.
Thank you, Sharon. Good morning, everybody. At the outset, I would like to thank Dr. Amit Mehdev and his entire team for inviting me to this wonderful meeting. I'll be speaking on this topic of biodegradable stent in ERCP, indications and future role. In this, I would be covering what are the biodegradable stents or the BD stents, their indications, advantages and disadvantages, and some challenges with these stents. What are biodegradable stents? I think that's important before we go further in this talk is they're made of complex carbohydrates, generally polylactide or polyglycolide, which are radiolucent, and hence they have to be having some radio-opaque material, which is either barium sulfate or magnesium embedded in these stents to make them visualize during X-ray while we place them. So exact positioning is important. They come in variable shapes, designs, and dissolution properties, which I'll allude to later in my talk. And they dissolve over a finite indwell time based on the composition of the stent, which can vary from few weeks to few months' time. These stents are degraded by natural physiological hydrolysis, and the end products are lactic acid and glycolic acid, or even glyoxylic acid. These end products are metabolized by the natural physiological pathways, and hence they do not have to be removed. Based on the dissolution properties, the stents can be fast or medium dissolution, which resolve by 2 or 3 weeks of indwell, and they're usually made of polydioxane. These are complex carbohydrates or polyethylene glycol. And the slow dissolution stents, which can dissolve by 11 to 12 weeks or about 3 months period, are made of copolymers of polylactic, polytrimethylene carbonate, and polycaprolactone. These are difficult terms too, but there are different complex carbohydrates which dissolve at different period of time. Why do we use them? In normal ERCP, which we use in our practice of pancreatic or biliary disorders, we either use 1 or 2 plastic stents or metal stents, depending on the indication. And then these stents can get obstructed if they're not removed after a finite indwell. And hence a follow-up ERCP is required to remove these stents or exchange the stent as a need be. So advantage that Sorry for the interruption, which was unexpected.
Check. Hello.
Is it okay? Sure. I'm sorry, I didn't see the previous slide. Were they visible or not? Okay.
Yeah, I think, Sandeep ji, now you have it. You were giving a lightning effect earlier.
That's my magnetic power.
Now you can deliver your thunder.
So now it's electromagnetic. Okay, so moving forward, the advantages that the biodegradable stents offer is that, yeah, it's quite clear now. So always look behind what's happening or on the sides before something hits you. Avoid repeat ERCP endoscopy procedure for stent removal and thus reducing the overall cost. So the biodegradable stents provide 2 advantages. One is you avoid a repeat ERCP and the complications associated with the repeat ERCP. And that's why they are an attractive option for sometimes benign and biliary and pancreatic diseases. So indications where they can be considered, they're not foolproof or there are no clear-cut designed indications as yet, but what we can imagine is most important is prevention of post-ERC prophylaxis for pancreatitis. We generally insert a plastic thin 3 or 5 French stent without flaps, which often migrate spontaneously in 2 weeks' time in 70 to 80% patients. But in about 20%, we have to call them back and remove them. And if you forget, then these stents lie inside and cause their own problems. So that's one most important indication of a prevention of post-ERCP pancreatitis. Even after biliary endotherapy, when you have cleared the stones or the sludge and you're not very sure that duct is totally clean, we often end up placing another stent and then the sequence continues. To stop this sequence or break this cycle, we can place a biodegradable stent which can allow the juice to flow out and the sludge to go beside the stent, and then these stents will fall off or dissolve. Same goes for pancreatic endotherapy. When you have cleared off the pancreatic stones and not very sure that everything is clear or not, and sometimes we have to place a stent because you've done a sphincterotomy. At that time, you can consider placing a biodegradable stents. An important indication where the surgeons use is prevention of post-operative bile leaks or a pancreatic leak, especially after a HJ or a PJ surgery. This is also considered by percutaneous intervention radiologists when they have done the procedures and they feel it's okay, but the leak can happen, to prevent that leak from happening. Can we do it in benign biliary stricture? We can discuss that. And pre-operative drainage of malignant biliary obstruction. These are two debatable areas, but also have been reported. The designs of these biodegradable stents are two different types. One is a straight like a plastic stent. These are called as a sinusoidal or a helical design. I'll show these pictures later. Intertwined stents from Archimedes. Another same company produces a stent called as balloon expandable stent, which is similar to a metal stent. So this is the plastic stent type variety. This is made of biodegradable. Comes in 6 French and 8 and 10 French. The 6 French is a different design with a tail having a biflange, whereas the 8 and 10 French have 2 flaps at the both ends to prevent migration. But they're made of the same material. They have slightly curved shape and they have a tapered tip or fluted surface. The diameters vary, length vary, flaps and the split end vary. All these stents have a central lumen for the guide wire to accommodate these stents to go in. And if you take the cross section, these are 2 spirals which are going like a double helix with a central hole to allow the wire to go in. So the juice drains not only through the lumen of the hole, of the central hole, but also around the side of the stent. This is how it looks like. The flap at the papilla, and the stents are placed exactly the same way when we placed like a plastic stent. And this is how they look like on X-ray. The radiopacity is because of the material barium sulfate of magnesium embedded in this radiolucent biodegradable material. We published our experience, a collaborative experience with other groups in Spanish Journal of Gastroenterology last year, and they found it to be safe and feasible. Moving forward to the next design, which is a little more excitable, is the balloon expandable biodegradable stents. As the name suggests, this stent is made similar, looking like a metal stent with a mesh, but made of a biodegradable material. It is loaded over a balloon. So this is how the stent assembly looks like. It's the balloon first, and on top of that is the stent. So you take the assembly inside and then expand the balloon, so the stent now remains open and embedded in the wall. This is how it looks like ex vivo, and you use a inflating device similar to what we use for other inflating balloon devices to reach to an optimum pressure, so to reach the diameter of the stent. Let me show some examples of these patients. This is a patient who had distal CBD stricture post cholecystectomy, and stent is being placed. This looks like a silvery material on top of a balloon. And once you're in a good position, then you don't move around, just stay there and inflate the balloon. Keep it for a minute or so, reach the appropriate pressure, so it reaches the diameter of about 10 millimeters. And once you have done that, then you deflate the balloon in the same position. Try not to move around because stents will be a little softer and can break, the lattices can break. In fact, you can see the dissolution starts happening right in the front. The foaming or the frothing on the tip of surface is visible. And this is how the stent would look like. You can hardly see anything there on the X-ray, but if you see this red area, the 2 black dots are actually the stent tips. The upper one is behind the scope, that's why we can't see it. I'll show you one more case. This is a patient who had multiple CBD stones with stents inside, where stones were broken. And when we're not sure whether the duct is totally clear, at that time we use this stent. Not able to move it forward. Okay. Here goes the stent. So this is how the picture looked like. This was the initial picture. He had ESWL, several stones were broken into small fragments. And then the balloon sweep done. The duct is reasonably clear, but we're not sure that some smaller fragments can get blocked at the lower end. So we placed the stent, which was dilated. Contrast inside, and then we see the stent. You can see on this image, but let me point it out for you. This area focus itself, and these two dots are actually the magnesium at the end of the stent in the lower end, and the magnesium in the end of the upper stent. So you need to have a good fluoroscopy to see where exactly and that's why sometimes putting the contrast in the balloon helps. We published another case of complex hilar strictures, the last few slides. Post-cholecystectomy, he had several stent exchanges, but the stricture was coming back again and again. So we resorted to this stent in a Y formation. This was a baseline stricture. There were two strictures at the origin of right and the left hepatic duct. And this is how the stent is placed, quite similar to a Y stent that is placed for a uncovered biliary stent at the hilum. So you first place the first stent, expand it fully, then go through the lattice of the stent to the opposite side, and then place the other stent on the other side. It may break a few lattices, but still most of the length of the stent is still intact. And that's how this works. So this formation was done in this patient. The video is not there because you hardly see anything there. It's only the X-rays, and these small dots will tell where the stent position is. We got a CT done a few days later, and you can see the end of the stents and aerobili on both the sides. And this is how it improved. The LFT changed at 2 weeks and 8 weeks after the procedure. The patient is now at more than 1 year of follow-up without any need for subsequent stenting. So in the end, I would like to conclude by saying that biodegradable stents in pancreatic and biliary disorders are safe and can be effective. The use of biodegradable stents, the most important indication they avoid is second ERCP. So if cost is a constraint, I think this becomes an important indication. The balloon expandable metal stents, biodegradable stents are an attractive option for benign biliary strictures and after CBD stone clearances. Stent migration is very unlikely with these BEBs since they are bare. It's quite similar to a fully uncovered metal stent. And time to dissolution and sustained radial force, it needs little more studies, but I think they will probably have their place in times to follow. Thank you very much for your kind attention.
Sandeep, there was an issue regarding the radial force of these biodegradable stents. You said print out and put structures also.
So not the common garden variety, the spiral type of stent, but the balloon expandable biodegradable stents can be used for stricture. And the way you can expand these strictures is by either you pass a balloon, expand it, and then pass this balloon stent, or you can do both the things at one time. Both methods have been described, and once you dilate, then you leave the stricture leave the stent which keeps the stricture open.
This BEP stent, is it polylactide stent?
So that's a commercial secret from the industry. They have not mentioned what they are made of, but this is some of the literature which is available.
I'm sure, Sandeep ji, it was a beautiful eye-opener how future is going to be. But would you recall 20 years back, we have used these polylactide
वो wrap up video देखो अभी सब
लोग.
Wrap up video.
They used to open up all by
अभी चालू होगा.
But probably this is not polylactide, so has to be dilated with a balloon.
Currently, these stents are very expensive, and that's why they're not very used widely. But hopefully, as the wider use happens, the economic changes,
but bold print
we'll have a cheaper version of these.
And these BIPs, how long do they stay? When do they disintegrate?
So the end struts actually within a week or so, those magnesium ends will disappear, but the stent remains there, as we can see by cross-sectional imaging. But they also start dissolving by about 2 to 4 weeks.
4 weeks?
By 4 weeks or so.
But is that enough to keep the stricture dilated?
That's a question. So if a stricture is very hard and not very pliable, the initial balloon will keep it there, but they may come back if the disease has a strong radial compression force.
Rajesh, what is your experience? Rajesh Nile Mehta. Rajesh, what is your experience of biodegradable?
No, I was supposed to ask Sandeep because he has used and I think he can give the gut feeling.
I had teleprompter.
Do you think they will be the promising because looks very good done in
वेळ
AIG,
लागेल.
I can see.
राहू दे,
So
राहू
what
दे.
is your experience like? What do you feel?
या
Will
पण
they
ते तरी
take the
खाली
market
बघितल्यासारखं
in the
दिसेल.
future?
They definitely
दिसेल.
have a market, but we need little more studies and some more actually randomized studies of what
नाही राहू दे, राहू दे,
treatment
राहू
that
दे
we have
इकडे
the current standard of
ठेव.
care.
थोडंसं वाचलं तरी चालतं.
To see whether they have a sustained benefit, as Dr. VGM was rightly saying.
ते आत्ताच मी बनवले बसल्या बसल्या.
They might come with the drug-eluting stents also in the future along with this.
Sky is the limit.
Thank you, Sandeep, for your excellent talk.
Thank you, Ramesh. Thank you very much.
Thank you,
Light
chairpersons
band.
and all the speakers. We close the session. Now we will go live from the beats.
Video. Video. पहिला व्हिडिओ. पहिला व्हिडिओ.
Amit, you're on and we can hear you, see you.
Yes, yes, you can see me, but before I start talking, you are going to see something, how this conference happened and what we experienced over the last 2 days. कमी करू नको रे.
A very dedicated international conference that include live cases with very practical tips by experts, with didactics, with fantastic video, algorithm, etc. So I think this makes it probably one of the best ERCP courses I've ever been to.
It's great to be here at ERCP Live, a very unique, single-themed, focused conference. The faculty is outstanding and the case selection is excellent.
First of all, would like to thank Dr. Amit Mehdev for an excellent conference on ERCP. I think it is like after a heavy summer, there's a good rain and you are getting a good weather. A dedicated therapeutic ERCP conference is very much needed for young gastroenterologists as well as those who are performing.
Hi friends. So now we have come to the last day of ERCP Live 2023. And to tell you the truth, this has really been an eye-opener for me. Because when I devised and thought about this concept of doing a focused ERCP meeting, not only me but many people who I spoke to were skeptical. That why ERCP? Everyone talks about advanced procedures, third space endoscopy, EUS, bariatric endoscopy. Why ERCP? We are going back. In fact, some people told me that we already learned, we already know ERCP. What new are we going to see in this conference? So I was expecting a response, an audience of only 250, 300 people, and I had started making arrangements of that nature. But I was overwhelmed to see that finally we got almost 700 attendees from our country, in addition to many international attendees, and attendees from 15 different countries also came for this conference. I would like to heartily congratulate all the speakers for their excellent, crisp, to the point lectures and with a very high academic content. And of course, all the demonstrators, as you can see, as you have seen over the last 2 days, we tried to schedule various types of procedures and tried to develop the procedures in a crescendo, starting right from the basics and went on to showing advanced procedures yesterday, and today are the big ones which are going to come. And for this, some more stalwarts from our faculty I have come here to BIDS to demonstrate to you. I really hope that all of you have enjoyed this meeting, and I hope to see all of you again in the future very soon. So let's enjoy the rest of the meeting.
Thanks, Amit. I think we should give a big round of applause to Amit and BIDS for this program. So congrats to the entire team.
So for the live session, may I invite the moderators for this first session, Dr. Sunil Jain, Dr. Lawrence Peter, Dr. Yogesh Harwani, Dr. Sanjay Rajput, Dr. C.C. Chaubal, Dr. Chetan Bhatt, and Dr. Mengraj Ingle.
This is our case? No.
So the first case of the day, a 40-year female known case of diabetes mellitus, hypertension, came with complaints of epigastric pain, steatorrhea, and weight loss. MRCP was suggestive of CCP with MPD of 14.1 mm in head region with multiple intraductal stones, evidence of incomplete pancreas divisum, planned for ERCP with pancreatoscopy and ductal clearance. This is the MRCP image. Dr. Nageshwar Reddy, you are live.
Yeah. So good morning everybody and welcome to this third day of live workshop. I think we've had some very interesting cases, and this morning also this case looks interesting in the sense that this patient had an initial ductal leak after after that an ESWL was done, and then stones have been cleared mostly. I have with me, directing me, Dr. Simon Lowe, so I'm sure we'll be successful.
I'll show you something.
Yeah, so she's going to show something, yeah, okay. So he's going to be with us along with Daftar, who's actually anesthetized the patient. But what we are doing unique in this case is something that I'd like you to see. I don't know if the camera can focus. What we are going to do is use this new type of, not very new, but actually scope that hasn't been demonstrated up to now. So we thought we should show a disposable duodenoscope. So this is very interesting because the first time we are actually opening it out, we open it out of the bag here, then take it out. I thought this is the important part to show that this has to be, there's a definite way of getting it out, unlike other situations. This is a plug and play technique where you just plug the scope inside once it's out. Yeah. I think, I don't know, the camera can see, yeah. Okay, just gets plugged in, that's all. And then There's a difference between this and the regular reusable scope. There are two differences. The first difference is this scope is a little stiff. So what I have to do is when you start using this scope, I'm sure Simon would agree, that it tends to be a little stiff, so we have to massage it a little to make it soft.
Yes, that's what we do.
So I just sort of bend it a little so that it gets a little bent. They are probably correcting this in the third generation, but this requires this. The other important thing is to check all the knobs, because sometimes when you get these scopes, some of the knobs don't function, so we do this. And the third difference is that actually when you're using the elevator, this of course you get only the feel. The elevator it doesn't give that resistance what you would expect from a regular scope. It's very soft, and the actual elevation angle is a little different from the standard scope. The important thing to remember is that unlike the disposable scope, when you actually turn it to one area, it stays like this. It sort of gets auto-fixed. You don't have to fix it with this. You can also do, but it stays auto-fixed. So that can be both positive and negative aspects of the scope.
Right, it doesn't recoil.
It doesn't recoil, yeah, that's it. So let's start the procedure now in this patient. I'll require some jelly. Suction should be attached. We require a little more suction, I think. So this procedure is similar, and then some air also has to come in. I can't feel the air, the carbon dioxide or air. Yeah. Yeah, you can, normally we tend to use carbon dioxide, but still it's not flowing through, so you have to fix it.
So Dr. Nagi,
yeah,
the processor and everything is different from the normal processor?
The processor is different. It comes with a different processor which includes everything in the processor. So you can see here, this is the processor that we are using. I think the camera can focus a little on this. So it's okay, The processor is separate, the XL processor. The advantage is that when the new generation comes, they'll upgrade the processor. That's the advantage. You can see the image quality of this is quite good, as good as the standard. You don't require narrowband or anything for ERCP, so it's okay. So I'm entering into the stomach. Little stiff scope, so I'm having the patient on little semi-prone position, not the true prone that I like to do. And then when I come, I straighten it up, and you can see a nice image here. I'm not inflating too much. I'm going to the pyloric area now, and then you see how nicely it slips into through the pylorus into the duodenum second part. Now I go into the second part, and then here the little stiffness matters. You have to be very careful not to push too much. I'm now doing the standard maneuver to get the scope, and you can see the image is quite good. Can you see the images there?
Yes, we can see.
So you can see I'm pulling back the standard ERCP.
Isn't it very dark as compared to the routine duodenoscope?
No, usually not. You can actually adjust the vision also. So you can see here, if you can see the again you can see the generator. There's a button here with which I can increase the brightness if I want. See, I can increase the brightness. So vision is very good. I mean, it's not very dark. Because of this ability to increase the brightness of the scope, I think you can. But also you can see very nicely in this picture that this patient had a very nice extracorporeal shock wave with a trypsy, and you can see small amount of fragments coming in. So what I'll do is I'll cannulate the pancreatic duct, and if you see the fluoroscopy, you don't see actual fragments now, which means again it's completely pulverized. So what I'm going to do is I'm going to go in now using the standard ultratome from Boston Scientific with a Terumo wire, which I would like to use in this case.
How do we justify this use of this scope over conventional ERCP scope? And what are the benefits of
Exactly, that's a very important point. In our country, because of the cost involved, it's very difficult to use it routinely. So an average scope, I think, now would cost about $2,000, so it's still very costly. Now, how do we justify its use? There are some categories of patients who come and ask us for a disposable scope, they can afford it. This is the category, or they're insured to the extent they can afford it. But mostly it is for using for immunocompromised patients. If you have a patient who is immunocompromised because of post-transplant or any other situation, this is one important indication. The other indication is the patient is already known to have severe cholangitis or resistant organisms, then you don't want cross-transmission. This is another indication. Sometimes people say in a situation where you want to do weekend ERCPs, you don't have the full setup that they can use it. These are the three major indications present. Simon, you want to add anything there?
I think it's the same thing for us. Even though our financial system is a little bit different, but it's still very costly. So we have to be selective of how we use it.
No, sometimes, Dr. Nagi, sometimes we use the same accessories. Suppose a patient is SPS antigen positive or he's C positive, we use the same accessory in those patients. We keep it reserved for them. So can we use the same cholangitis or immunocompromised patient, the same scope?
No, I didn't understand the question.
No, sometimes in hepatitis B or hepatitis C,
Yeah.
we use some accessories in ERCP and we keep it sterilized and keep reserved for the same patient again and again.
So you can't actually sterilize this scope. It's a disposable scope. I'll show you later on. You can't sterilize it because can you pass the wire inside now?
I think situations like AIDS, cholangiopathy and all these things, there also I think this can be preferred.
Yeah, but again, I think the indication is, wait 1 second.
Nagi, what is going to cost of this particular scope in INR?
It's approximately about 2 lakhs and odd. Again, it depends on how you negotiate. So you can see the opening here, little eccentric. In this case, this is the opening. Now can you put your wire inside? You can see the scope. One of the problems is the elevator. It's not coming out very exactly as I want it, but still it's okay. You can still use it for simple cases. There's been a nice study from Sham's unit which actually used this scope. See, there's some block there I'm finding when I'm trying to get inside, but I'll negotiate the through with the thermo wire. So there's Sham's study published in Gut. Now can you pass the wire? We showed very clearly that, so this is inside the duct now. There is something hitting the wire, so it's not going through very easily, but we'll try. The study showed very clearly that for difficult grades of ERCP, that is grade 2 and grade 3, it is not very easy to use. But simple one, grade 1, the Schultz grading, it was no problem. So this is a scope which can be used by those who are doing ERCPs quite a lot. Little more experience is required compared to regular scope. The angle you can see is little different from what you get, but the views are fairly good. So again, I'm trying to now negotiate the wire through this very difficult opening here. Well, just 1 second,
Nagi Mohan here.
Yeah.
Are you using a 3rd gen scope or 2nd gen scope?
I'm using 2nd gen scope, yeah.
Okay.
3rd gen is not still available for us for clinical use.
So you probably, with the regular ERCP scope, you would have cannulated this in 5 minutes? Or 2 minutes?
No. This cannulation is easy. Okay. It's a question of the wire is hitting against a stone fragment there, which I have to now try and dislodge, which we will do with the thermo wire. Now we are deep inside. You can see cannulation is okay, deep inside.
Would it help if you give some contrast?
That's what we'll do next. But generally what happens is we can get a wire deep in. So what I'm doing is I'm trying to pull back the scope a little and then try and get it through. So you see, Mohan, nicely deeply cannulated.
Yes.
I'm in the pancreatic duct.
Very well.
I'm trying to pass the wire through, and because of some obstruction there.
Can you enlarge the fluoro?
No. So I think what we will do is, So we will ask, as Simon suggested, that's a good suggestion to have some contrast in now at this point to see how exactly the flow is, whether the obstruction is there. Yeah, okay. We'll come back a little now.
Is it infiltration, you think?
Yeah. So there's been a leak also in this patient. So now, now, okay. So there's been a leak in this patient, probably it's going into that area there. We'll see, we'll try again.
You're using an angle,
you can see
thermo?
We're using a thermo wire, always pancreatic thermo wire to start with. Now I'm trying to get it closer here, and then, so this is a little challenging case. Now you can see the duct going up there, and now we have to get through that narrowed area to get to the duct.
Excellent technique. Excellent technique.
Very nice. Now I get deeper in. See that?
Very nice.
It's very important to guide.
Nagi, did you hear the round of applause?
Yeah, I heard that. I think you are clapping near the mic, Mon, so I'm hearing that.
No, not true.
Okay. So I get deep inside. In this case, I think what we'll now do is change the wire, and we will do a careful pancreaticogram to look at the anatomy. Again, coming back to the point of cannulation, you can see what happens to the cannula with Exalt. It comes straight up. It doesn't come across to the other side. That is, it's more up like the other scopes, like the other company scopes. But I think the important thing to remember is that once you cannulate, everything else is same. The optics are same. Can you see the image now? I think image is quite good. So quickly I'll now put in
enlarge
some
the fluoro. Enlarge the fluoro.
Enlarge, yeah. Fluoro should be enlarged.
That's a good picture.
Yeah.
So Nagi, we will allow you to do the pancreaticogram first.
Yeah.
And then we'll quickly shift to the other room and then come back to you as you are going ahead with the sphincterotomy.
Okay, we'll do that. So there is tight stricture there, beyond which, so this stricture will require a little dilatation, but so I'll do the sphincterotomy, dilate this, and then put in the...
Any leakage can we see?
No,
can't see any leakage,
there is no leakage. That's a side branch which is taking off.
Side branch, that's...
So the leakage has stopped now, I think, after ESW.
Yeah, and that's, I think, a persistent duct of Santorini leading to the minor.
It's going to leading to the minor, right.
Okay, Nagi, we'll leave you for a short while. That's excellent technique of cannulation you just demonstrated.
So what I'll do quickly, I'll do that. I think you've already seen a lot of pancreatic sphincterotomies, so that's okay. You can then come back after.
I can you start a little bit so that at least they know what direction to cut.
So you can see it's very important. I'm using my right hand on this shaft here.
Focus on his right hand.
And then putting the elevator up and then pulling the scope back.
Look at the hands of Nagi. He's pulling the shaft back.
Yeah.
So again, he's controlling the whole thing by the shaft of the scope. The very important message for the youngsters.
Okay. So now it's done.
Okay, Nagi, we'll just quickly go there and come back to you. Huh? So shift to Dr. Moon.
Yeah, just
this is a 55-year-old female. History of ERCP with CBD stenting 8 years back for choledocholithiasis, status post cholecystectomy. Now complaints of right hypochondriac pain with fever since 15 days. Ultrasound was suggestive of biliary stent in situ with no pneumobilia. ERCP done outside. Dilated CBD with a fragmented CBD stent in IHBRD. Now planned for ERCP and stent removal. This is the fluoro image. And Dr. Jong Moon, you are live.
Good morning.
Hi, Jong.
Namaste. I will introduce all our teams. Again, world best army team. Amazing assistant. And my moderator, could you say hello to...
Harshal.
No.
Harshal Gadikar comes from Pune.
Pune.
Yeah.
Pune is very nice.
He's an expert.
Nearby Mumbai.
Expert ERCP specialist.
Great. We are world best team. Say hello. Everybody say hello. Hello.
Namaste.
Okay. Namaste.
Namaste. Hi.
Yes, you already did the case presentation for this lady, and this lady did some, maybe it was the stones, maybe difficult stone, and the local expertise did the stone removal, and they put the pigtail stand, but unfortunately, the stone is segmentally remained in deep portion of left hepatic duct, almost deep portion of B2.
So where is this stent fragment which is inside the bile duct?
Yes. Can you see the fragmented pigtail on proximal pigtail on deep portion of...
it's in the left hepatic duct.
Left hepatic duct. So a local expertise expert asked to the surgery for this patient. So that's the reason why we are trying to save our earth. No, save our patient. So let's try to remove that kind of deep portion, the pigtail segment.
So what is your plan, Jong? You want to go?
Wow! Bora! Amazing!
Wow!
Amazing! Fantastic! So maybe it's not outside the bile duct, right? Let's keep going. I very trust about Bora and his team. Keep going, Bora. So my Facebook friend.
Wow. I think this shows the strength of Amit's team. why Amit is successful in 100% of his patients.
Good.
I think the technician is paramount importance.
Yes, so always we should respect our assistants and technicians to make a successful procedure, and patient safety can be the first. And now
it's in a peripheral duct.
Yeah, could you?
I think the
intrahepatic. So is it located intrahepatic or it is in the duct?
We don't know. It's maybe it's already infiltrated in the liver parenchyma.
Yes. Yeah, yes, it is in
maybe.
liver parenchyma.
So for my plan today, the only option is I call it over guide-wide snaring. After successful introduction of guide-wire.
So what is Seja trying to do? I think he's trying to cannulate the stent with the wire.
Yeah. At first, we need a successful cannulation to very deep portion of B2, and then over the guide wire, traveling snare at just a small opening of the snare, and traveling over the guide wire.
Yeah.
So insertion.
Almost.
Yes, the proximal point of the fragmented stent, and then we would like try to hooking, and then catching and removing.
Yeah.
It's only option for the interventional ERCP for this poor case.
Can you please focus upon
And also
surgeon's hands also, how he manipulates the wire? Can you focus on it?
Contrast.
I mean, it's very important.
He's rotating with his finger.
Yes.
Yeah. Contrast. So if possible, could you show my assistant manipulation? Now he is moving guide wire. You are using now Terumo, right? Terumo guide wire. Terumo. Almost to keep the...
Maybe
Is it a straight Terumo or a J Terumo?
Angled Terumo. Angled Terumo. So basically, I'm very trusting about Bisiglide 2 angled 1, 025.
Why the dye is not going into that radical?
Yes, we do not.
This is a block?
We do not see the dye going into.
Yes, it's true.
Stent.
Maybe it's already over.
Is this wire and the stent?
Yeah, I think that's a good idea. We should inject a little contrast, Seja.
Yes, we are doing, but the contrast is not filling completely.
Yeah, because if that duct is not getting filled,
yeah.
that means the stent has gone in the parenchyma.
It's already incorporated in the liver parenchyma. I think so. So without insertion of guide wire, any instrument can be impossible. So just we try more, and I would like to push caster bore.
So maybe one of our US expert can do a US guided stent cannulation through the liver.
But for that one, we need some dilated bile duct.
Correct.
So without dilatation, it's already stent is incorporated
two-dimensional
or
approach,
liver
yes.
parenchyma. It may be also difficult. Maybe. So Amit.
Yeah.
If we leave that kind of already incorporated plastic stent, it can make a problem.
Dr. Amit?
Yeah.
Like if you look at from the confluence, even the secondary duct has not filled.
Yeah.
So there must be some stricture or so. Can we try an occlusion cholangiogram at this level to look where the ducts are moving?
Okay, we are going to allow you to try here for a little while. We are going back to Nagi because Nagi has made a lot of progress there.
Okay, thank you.
Yeah. Shift to Nagi room. Hi Nagi, we are back with you.
Okay. So what we did is, as you're aware, we dilated the stricture. I don't know whether you have the fluoroscopy pictures of that.
Yeah.
Dilated very nicely.
Enlarge the fluoro.
Yeah, very nicely dilated. It was
enlarge the fluoro.
Yeah. So we dilated the stricture to 6 millimeters.
Yeah.
And then a lot of soft fragmented material came out completely.
Okay.
And now I'm planning to put a stent here. The plan is we probably have to put in 2 stents or 3 stents graded over a period of time. First one now, and after 3 months the second one, and after another 3 months the third one. This will completely take care of the patient's therapy. Now this is the stent now.
So you have put a 5 French stent?
I'm putting a 5 French stent now.
Okay.
But I'll come back later after 3 months.
Okay. So I think it was a fantastic demonstration of the
Amit,
use of
before
the
we leave, just one more thing I want to show the audience.
Yes.
If the camera can be on me totally, now the procedure itself is over.
We're not seeing you. Yeah.
Now,
Only
can you have the full
room picture?
Room picture. I want to show you something which is
Something
interesting.
dramatic.
Yeah.
Yes.
So now see the procedure is over.
See, now he's going to show you something interesting.
Yeah. So I take out the scope.
Yeah.
This person.
I take off the.
Sir, is this process the same what we use for spy cholangioskop or it's different?
So now.
See what he's doing. See what he's doing.
Into the waste paper basket. That's all. It's over.
Yeah.
So, Nagi, you
yeah.
always advocate about green endoscopy.
Yeah.
What about the environmental pollution? by
Yeah. So this is a question that I knew would come. But so what they're now doing is that they're now making a method of biodisposing the scope without affecting the environment.
Oh.
So there's a study which has shown comparing cleaning of reusable scope versus doing a proper disposing biodegradable scope, and the amount of carbon footprint is less with this type of biodegradable scope if you do it in a proper way. So ultimately that will come, because without that we can't proceed further in this type of scopes. But yesterday I think we had a very interesting concept from Barham, who showed us that it is not for infection, which I agree with him, but it's going to be more for a new platform that is going to change the way we do endoscopy.
Yes, yes,
Simon,
yes.
agree?
Sir, can we put the 2 or 3 stands on this sitting only, because picture
We
doesn't
could-
look
we-
there?
yeah, we could
because
do
it will
that.
save the time
Exactly.
and as well as the procedures.
It could do that, but remember this patient had a leak also recently. I didn't want to push in too much pressure there. That's the reason why there's no hurry, because she now decompressed the proximal part of the duct. The stones are completely clear. We can come back and do it in the second sitting. There's no
So that was a superb demonstration,
Thank
Nagi,
you,
at
thank
the good beginning of the day.
Thank you. Thank you.
So you have some more cases to do, so we'll quickly shift to the other room.
Okay, thank you.
Dr. Moon, shift to Dr. Moon.
Thank you. Great job.
Okay. Could you remove the catheter? Okay.
Yeah, so looks like we will not be able to take this stent out because it has gone inside the parenchyma.
Yes,
So I think we can stop this procedure here. Are we
Yes.
ready with another case?
Just push.
Yeah.
Just
So Dr. Moon, so what is your suggestion? What surgery should be done here now?
Sir, my suggestion, if she is my patient, I just watched out. So any possibility of complication of
Yeah,
the
agreed,
abscess
completely agreed.
or cholangitis,
Yeah.
without that kind of complication, I just leave it down.
Leave it alone.
Yeah, leave it down. And
So if this patient has no symptoms because
Yes.
these are not, it is not inside the duct, we
just
just don't do anything about it.
Just to let us show to how would like we do today. Maybe some doctors are interesting about this one, and could you sneer over here? And this
Yeah.
is a guide wire.
Endo picture.
This
Sir,
is guide
this
wire. So
this
it's
patient
very
has been tried by IR people also.
Endo picture nahi hai.
very
Room.
very useful escape procedure, and like a hooking guide wire here, like this, and snare. Could you see the snare here?
Yeah.
And then ask to the assistant traveling over the guide wire, and
Okay, the snare.
don't close too much, and then like this to working channel.
Okay.
So and travel over the guide wire, and then if you can imagine the stent fragment is like the end of the wire, you can see the snare is on endoscopy traveling over guide
Larger
wire.
fluoro picture.
So this patient has been tried by
Yes.
IR people also,
And then,
they could not cannulate the
you
same
can
duct.
you can see
So
the very
I
easy
think better will be the surgery.
insertion
Yeah,
of the
yeah.
snare over the guide wire.
So we can see very
yeah,
well.
Yeah. So and then if the stent is here, we can make a success.
Correct.
So
correct.
for the after, could you open the snare?
What snare are you using,
So
Professor Moon?
thin one is good. You like a EMR.
The EMR elliptical snare.
Yes, elliptic. Yes, good. So thinner one is better. Now you can see the barely seen the open the snare, and after catching the stent, and then remove the stent with fluoro, please, with like a guide wire.
Correct.
Guide wire and stand and the snare and then slowly remove from the bile duct.
Correct.
And it's very useful tip also removal of pancreatic ductal stent. We already reported
Yes.
about several cases.
Yes.
So I'm sorry about
So
for
thank-
this lady. It may be impossible for interventional procedure. So sometimes you should forgive our procedure to save our patient.
Yeah.
So,
So thank you, Jong, for this superb demonstration.
Thank you.
And let us shift now to the next case.
Thank you. Thank you.
A 58-year-old male,
Maybe
known case of diabetes
maybe
mellitus
it's
and
no
CCP,
problem.
came with complaints of epigastric pain, steatorrhea with weight loss, history of multiple sessions of ESWL and ERCP in past for PD stone disease. MRCP was suggestive of chronic calcific pancreatitis with dilated MPD with interductal calculi in head of pancreas, planned for pancreatoscopy and ductal clearance. Dr. Rungsun and Dr. Thavi, you are live.
Good morning. Good morning.
Morning.
Welcome to Thailand. Sorry. Actually, today is Thailand and Indian team work together. As you heard from the story, actually this patient underwent multiple ERCP already, but there's some residual stone left. I take the luxury in terms of getting to the site, and we found that in terms of more straight shot, many times, working through minor papilla, is it wide open, will be easier.
Right.
So what I can see in this, as you can be confirmed by fluoroscopy, that we are in a long position, and you see that this is being cut somewhat. So I'm just gonna go ahead and first evaluate with
Fluoro picture,
pectogram.
please.
Yeah, so
You can see the long root of the scope.
Yep.
And wide view from the Fuji new.
See that it's more straight shot by doing this.
Right.
I mean, you can just do whatever like you comfortable with this position, or you may try to pull back or shorten your duodenoscope after this. But I would go ahead and start with this magnetogram. So let's do injection.
So Rangsan, in this case, actually we have done multiple times ERCP.
Right.
And after ESWL, there's one stone which is just not breaking by ESWL.
I see.
So that's why we have kept it for you.
I see.
So that you can go in with a SPY, go in the pancreas and see whether it can break with a thulium laser.
Right.
So we're gonna hunt for that stone that you're talking about.
So it's a recalcitrant stone.
You can see upstream irritations and then
Yes.
the
Maybe some filling defect here, but I don't see.
Where is the
Maybe
stone?
there's some here, over near the the end of the opening.
Can't
See
see
that?
it over here well.
Yeah. It's already obliterated by contrast.
Yeah.
Maybe check by SPY.
Yeah, we're just gonna go ahead with SPY. I guess that's the best way
I
to
think
do.
I suggest that you just clean the duct once with the saline.
Yes, I would do once.
Yeah, saline,
clean,
saline.
and maybe I can do some simple sweep just to see. Because I don't know the opening. I guess because it previously was with 10 friends, then it should be big enough.
Amit, in your experience, how many stones are refracted to ESWL?
Okay.
Amit,
Inject more
in your
saline.
experience, how many stones are refracted
Okay.
to ESWL?
Very rare, very rare. This is one of the very few situations.
Not much, huh? So I think better for us to go directly and see what and where is that stone.
Because of the contrast, you put SPY in.
Maybe there at the distal end.
Yeah, normally
that?
contrast is oily. So when you put SPY
I think
in,
just
it
clean
may
the
not
duct
clear.
with normal saline.
Yes,
Yeah.
yes.
Flush it, Shubhada, with normal saline.
We
Enlarge the
aspirate
fluoro,
and part
please.
with saline.
Enlarge
Do the
fluoro.
X-ray, big, fluoro big.
Bigger fluoro? Yeah.
Yeah.
Maybe
yeah, yeah.
I think we see some filling defect near the opening.
Yeah, once we put the SPY scope inside, we'll see everything.
Yeah, we can take a look. I think we can exchange and go with the SPY.
Yeah, we can go with the
do-
SPY and irrigate
and
it.
do examination.
Yeah,
Yeah, we can try that. Why may be better because opening is not so big. So let's exchange the Y first.
Yeah, you are going to dilate with hurricane, right?
It's a good idea. I think it's
yeah.
let's do dilation.
Yeah,
we can
yeah.
go directly.
Yeah. A little dilation and then
maybe
SPY.
8 because this big duct. Yeah, I want the big one. Sometime at home we put a fully covered stent for a few weeks, and then that such stone will come out spontaneously with this stretch shot.
Yeah.
So pancreatic sphincteroplasty, we also have to give small cut as we give in CBD
Well, to me, I think as long as the duct is dilated, I don't worry about it. I'll go by the side of the dilated duct. So in this case, we select 8 millimeter balloon to open up the.
But yes, KK, for any pancreatic sphincteroplasty, you have to cut first and then balloon.
Yes, this is already cut.
So the side balloon depend on the related diameter of the PD.
So my only question here, Rangsan, is again your scope is in a loop position.
Yes.
You can't straighten it because passing a spy in a looped scope.
Yes, I think after that I will do that. I just have very stable position with this. So I think as soon as we open up the access better, I don't have to worry about to get in with the spy scope anymore. And with that, I totally agree with you that after we get access, very good stable position, then we can do the shortened position.
Okay, okay.
Going with the balloon now. So this is
Use a Hurricane 8 millimeter diameter.
Right there. Okay.
Yeah.
Inflation.
Enlarge
slowly.
the fluoro.
Yep, slowly. Very good, very good. It's coming up.
You can see the small waist.
Yeah, small waist line there. It's not bad.
Yep.
All right, go on, go on, go on. So you want Thai time or Indian time? 1 or 2 minutes. That was a good joke yesterday.
Right now it's about 8 ATM, the west cone.
Yeah, I think we're fine.
Sir, this stone appears to be in proximal part of PD. So will it be difficult to position our spy scope there?
Well, we'll see. That is, because I'm not sure where exactly the stone, but my guess is somewhere, near this balloon. So as soon as we get in, we will do that. Okay, you can deflate it now.
Or maybe gone. Right now we cannot identify the.
Yeah, I'm not sure what is this, but let's see. I think actually when we run the study in terms of having a spy to check the CBD stone, I think we would do the same in terms of pancreatic stone, because I think sometimes those fragments you may not see by over injecting with the contrast.
Amit, when we use dye in the balloon, it doesn't last long. So we usually use air. So how to know whether the waste has obliterated or not?
Actually, in our department, Sejad has mastered the technique of cleaning the balloon even if you put dye. And with that, it lasts long.
Amit sir, in your overall experience, how much maximum you have dilated the minor papilla? Apart from
minor papilla, up to 12 mm.
So we're gonna do 2-man technique, Indian style. So we're gonna be my pancreatoscopist, and right now I already shortened my scope, and I can show you, show fluoro that my scope is very close to the opening. Can you do fluoro to demonstrate that is there any residual structure left? But I think we are pretty good. Get close to that one.
So now you have straightened the scope.
Yes.
So the spy will go in relatively easily.
Sure.
Sir, can we push the stone above like in CBD because the duct is dilated above, and then put the scope?
We are still not sure, Sanjay, where the stone is. I'm not
we
sure.
Still don't see. We're still not convinced by the pentagram. So I think we better check by the pancreatoscopy directly.
Yeah, I'm not sure whether the stone is in the juxtapapillary region. I think it's still above somewhere. We could not actually see so well.
Regarding the contrast in the balloon, we've been using initial 2-3 mLs of contrast or 4 mLs of contrast, and then use distilled water to flush it into the balloon, and that we have seen that the balloons last much longer.
Is it?
Okay.
See how easily he has entered now inside the pancreas. Now let's get a pancreatic picture and irrigate.
So now my job is over because I have to be stay still and then up to Tavi and just tell me how to go up or down.
A little bit more inside.
Yeah, okay. We have to irrigate now.
Yes.
Shubhata?
Some resistance here, and I encounter some resistance, but I think we going in right now.
Yeah, scope is going on the wall. Can you do fluoro?
Yeah, fluoro is good. So we need some water.
No irrigation is going.
Yeah, water doesn't come out. Okay, that's good. That's good.
Now you can slowly pass
this
the
is stone there.
Yeah.
I think that would be a stone. Yeah.
Not yet. Not yet. Keep on going in. see the fluoro?
Below
Fluoro
the
on.
scope, there is a stone
Yeah,
on
I think there's some white stuff over
if you
there.
withdraw the scope, you will be able
let's
to see.
Let's see.
Sure.
I think we pass some.
The picture is not so
Yeah, we have
clear.
to clean it with.
Clean the.
Yeah.
Keep on giving water.
Right. Yeah,
That's
yeah.
the stone.
I think we are a bit deeper than stone now.
But that stone is not very big.
Pull back a little bit here.
Actually, Rangsan, if you take out the wire, no, your movement will be much better.
I think so. It's better, and it's obstructing my view because I have to put the laser probe anyway.
Now you can see it better. And now try to go. If you can push the scope.
I think we see the stone now.
Yeah.
Right, right.
We can see the calculus, yes.
Right. Yes, so we would start hitting this one. So normally, many times there's some difficulty to go in if you, load the probe later, but we will try. Many times, like yesterday, I think, who was that? Try to go in with the preload with this laser, but again, the challenge is to go in freehandly with the spy scope.
So
but
one trick we do is as she's pushing the laser fiber, as Thavi is pushing the laser fiber inside,
I pulling back.
Once he starts getting resistance, you start pulling the spy scope back.
Yes, exactly. That's what we do as
exactly.
well at home.
You do the same trick, right?
Right.
And the same trick can be used to pass the spy bite also.
Sure.
Pull it back a little bit, and then along with the forceps or along with the fiber, push the scope inside.
So I mean, it's important between the one who placing the probe of the laser that he encounter any resistance or not, and I drop all my elevator and also big wheel as much as possible. If he encounter any resistance, I start pulling back my scope.
Yeah.
My spy scope. Still going in? If not, let me know.
Has it gone inside, Thavi?
Not yet. Some resistance.
So I pull back a little bit. Here we go.
Try to put in.
Yeah, keep on irrigating,
Yeah.
Are you okay?
Or you can even pull the scope back.
Okay,
oh
here
yeah,
we go.
beautiful.
Here we go. So I'm pulling back a little bit, so I'm just going to go deeper
Very
to get
little bit
And
back.
the techniques, sometimes you can
Now
move.
push the scope inside again.
Yes, pull back the probe a little
Very
bit so I
little,
can go in with my scope.
Now
Okay.
going in. Excellent. Very nice demonstration.
Can we have the fluoro images?
Oh. Okay. I think that is the stone there. You can see that radio
Yes.
opacity. Not this.
This is the wall. This is the wall.
Yeah. Go inside more.
Okay, I'm losing my position here.
Yeah.
And I
Go
get
in.
close.
Go in. Go in. Go in.
Let me
Go in.
hold on. I lose. Okay, I slip out with this
It's come
position.
out.
That's okay. Let me go back in again.
Okay, we'll go to the next room. We'll go to Dr. Takao for the next case.
58-year-old male.
I think so.
Came with complaints of jaundice with pruritus since
Okay,
1
can
month.
make the
Fever
videos
on
go-
and off.
Can you switch the
Weight loss of 8 kg since last 1 month. MRCP was suggestive of mass lesion at hilum with type 3A hilar block with hepatic artery encasement and periportal lymphadenopathy. A total bilirubin of 15.1 and CA99 of 14103. Planned for ERCP and uncovered SEMS. This is the MRCP image. And Dr. Takao Itoi and Dr. Bapai, your life.
Good morning.
Good morning.
Are we audible?
Yeah, you are audible.
morning.
And Dr. Priyanka, can you please shift the, change the moderators, second set?
Oh.
Right. So we have Dr. Takao over here, and you saw the MRCP. So Takao, my first question to you is, how many stents and where? So
How many?
Thank you, moderators. Now, may I invite the next set of moderators, Dr. Sudipta Dar Chaudhary, Dr. Praveen Rai, Siddesh, Pankaj Desai, Ravi Gupta, Srihari, and Vedant Karwar to take their seats on the stage, please.
Okay, back to the discussion.
yeah. So how many stents and where all would you want to? Meaning, if you're looking at 3 stents or 2 stents.
Yeah. So MRCP showed, I'm not sure, but separate anterior, posterior, and so left side, left branch. That's why, so if necessary, we press a 3 stent.
Okay.
For complete so decompression by that. However, the stent, the size is limited. Now we have only two 10 millimeter in diameter metal stent. So 3 10 millimeter in diameter stent is too much. So that's why we have to at least 2. Right. So one option is posterior, posterior and anterior. And then later HGS.
HGS, yes, because I think Ceres is the kind of terminology that I think Pradham Chai has designed, the Chula group have demonstrated that they put 2 stents on the right side and 1 on the left side with HGS. So that's also a good consideration if we're limited by the number of stents.
The other option is
as we saw from yesterday's lecture of Dr. Rangsan, that the basic principle is we have to drain at least 50% of the liver for any benefit. Second principle is not to drain any atrophic lobe of the liver.
Right.
And number of stents is immaterial. If you for 50%, if you need 3 stents, you have to put 3 stents. If it can be done in 1 stent, 1 stent.
Right.
So I think that's what we learned. And Takao, now you're the master. You can continue. Show us how you're going to cannulate now.
Okay. Firstly, cannulate, I use Quebec 3 with bisagride. So relatively the papilla is not so bulging, and I guess NDS, narrow distal segment, long.
Okay, 1 minute you hold on, Takao, because Rangsan is located the pancreatic stone and he's going to do laser. We'll come back to you in 1 minute. Rangsan.
Back now?
Yes.
Okay. See that I encountered slipping of my scope. So what I'm doing now, I went in freehandly with the long scope position, which is much more stable. And then so we're able to target it quite well. The setting right now we use 1 joule with 8 the megahertz. I mean 8 hertz.
See, this is very important because this stone was not breaking with ESWL, but this thulium is making a big difference here.
Sorry. Okay. I'm back.
Hard stone.
Very hard.
See,
so this setting, this looks very nice.
How much current you're giving?
1 joule.
That's it, only 1 joule?
Yeah. I think we can go a little bit higher. I mean, we can go to 1.2, 1.5. 1.5 try. Yes, try that.
Excellent. Oh, yes. See, this is the difference. If the 20-watt holmium laser and this is 35 watts thulium laser. Fantastic. Superb demonstration.
Very strong stone. I mean, to me, it's much more stronger than CBD stone in general.
Yes. And that is the hallmark of pancreatic stones.
Amit, what is the advantage of this laser over the holmium?
Oh, there are a lot of advantages actually.
1.5 is better.
The whole technology is different, thulium and holmium. And
see
here
some fragments start, breaking out.
We can increase the wattage up to 100 watts also, if required. And it has got various functions, including dusting, powdering. This is commonly used by urologists. This is the very, very few applications for gastroenterology. But we have just started using it in gastroenterology now because it is supposed to generate a little bit more heat than holmium laser. But in the CBD or in the dilated pancreas like this, because we are constantly
to become too big fragment now?
Yeah, because we are irrigating with fluid, that heat does not come in the way. Heat gets dissipated immediately. Beautiful.
This is a true hard nut to crack, I think.
Yes.
And Amit, please tell us, is there a risk of over-infusing water or saline into the pancreatic duct?
Yes, that can always be a risk, Mohan, but because we have done a balloon sphincteroplasty, whatever he is putting inside is water is coming out back into the duodenum.
And we have the suction port, intermittently.
And this sucking also. I think this was the highlight of this demonstration. Fantastic demonstration.
I think we're just like astronaut who, breaking asteroid.
Wow.
we move to the new space now. Actually, this is
okay, Rangsan, we will allow you to complete the job, and we will go back to Dr.
Thank you so much. Thank you so
much. Great job.
Thank you.
Takao, you're already inside?
Already we got in the bile duct, and
we got a left hepatic, the wire in the left hepatic duct.
So, Amit, do you want to see air cholangiography instead of the contrast?
We may do a air core, but definitely no contrast. Okay. So I think you can demonstrate air cholangiography. So for that we'll have to reduce the kV of the X-ray machine. But is your catheter going in easily across the stricture?
Yeah, very tough stricture.
Very tight, but he's
very tough stricture. I guess.
Because if it is so tough, then putting a stent also will be difficult, right? So you'll have to do hurricane dilation.
You probably have to dilate that. Once and also the wire, once it goes deeper, then probably it
or otherwise we have to use some special catheters which are brought by Takao from Japan.
One of the dilator is a very nice dilator.
And the one from Xeon Medical?
No.
There is
the
they
Olympus.
also have a dilator which I have seen.
The balloon dilator is Kaneka.
Okay.
And this is a very tough. So I guess another dilator is much better.
Okay.
Screw type.
Screw type. Okay.
And before that, the cannulation is relatively difficult. That's why. So we hope.
So Takao, there's no need of air cholangiography here because I think you're quite good inside the left hepatic duct.
See, with this wire has gone in the left duct. And the stricture is too tight. And I think there are two strictures. Segment 2 and segment 3 both are individually blocked. So if we can put only one stent, would it be preferable to have this wire first in the right duct, then maybe the left duct, because we can do the left duct with EUS guided if required?
Yeah, so that is a discussion which we had, Takao and I had just before we went live. That we can either do right anterior and right posterior and leave the left duct for another day for EUS, HGS.
That's true.
But Takao feels that he can also do a duodenum to right posterior duct if the need arises later. So you have to choose based on your comfort level which two ducts to stent.
My suggestion was for those who are not Takao Itoi.
I know. None of us are. So I would also be more comfortable with an HGS rather than a right posterior duodenum approach. So that's what I told him.
As we talk about that. Anyway, so before the Amit, so I guess the stricture tough, and I'm not sure the air cholangiography is completely performed. I'm not sure.
No, so what are you doing now? What are you doing? You are doing a sphincterotomy first?
From here?
No, not for, we'll have to go across the stricture proximally. Without
for
that,
air cholangiography, you'll have to go across the stricture.
Otherwise, we will not get.
So Amit, yesterday it was told that we should use CO2. So how to take CO2 in the syringe instead of air?
No. Air cholangiography is good enough. CO2 is not necessary.
Not necessary.
When we are doing an air cholangiogram, it's 10 or 20 ml of air that we are injecting based on the
Only
so
20
ml. It's not a continuous insufflation that we are doing. So that is not very unlikely to cause air embolism. Meaning I've never heard of any air embolism.
So Takao, I think you'll have to dilate this stricture first with your catheter and then do air cholangiogram. And maybe before that a sphincterotomy.
Okay, dilator. Okay. And
maybe do a sphincterotomy first and then dilate.
Sphincterotomy.
So, exactly. Sphincterotomy first. EST first. Okay, back studio. Okay, going back to sphincterotomy.
So Amit, you have really kept very tough case today.
Yes. That's what I was saying. You know, it's like Maharashtra, we have this Ganesh Chaturthi festival.
Yes.
On the first day, small Ganpatis go. On the fifth day, moderate. And on the last day are the big ones. So this is like Ganesh Chaturthi of endoscopy.
Okay, so the direction of the EST, biliary pancreatic orifice is 11 o'clock, like this. Little bit more up, more, yes. maybe relatively big keyhole is needed because for 2 metal stents at least. And
so I think that's a very important takeaway, that you have to do a wider sphincterotomy as compared to when you're planning to put one stent.
So wider sphincterotomy, why? Because there are two metal stents?
Because 2 metal stents and we have to go alongside the wire and the first
Correct.
thing. So that is
Good
an
point.
important take.
Looks nice.
Looks nice?
Yeah, looks nice.
Okay.
Okay.
Now let's see your special catheter.
Yeah. Special dilator.
Special
okay.
dilator.
Dilator, okay.
Professor Ito, if you have any difficulty in cannulation of peripheral duct, would you use a spicolangioscope to selectively cannulate?
Is one of option. But so it should be cost effective. Expensive, that's why. So if possible, if we get a nice assistant, so the firstly is under fluoroscopic manipulation, much better.
Yeah. And Dr. Vijayam, another challenge is that when you are doing a cholangioscopy, you are going to insufflate a lot of water. Now, after putting in that much water, if we are unable to get a wire in, we are in deep trouble then. We and the patient. Yeah, it's a disaster.
Yeah.
So that's the biggest. We usually will not put contrast or anything, meaning we are careful of.
No, but Amol, getting nice technician is also equally costly.
No, of course. Meaning if you can get a wire across, that's fine.
So you can see a very nice screw type dilator. You can see new one.
Oh.
Can we have the endoscopy picture?
Yeah.
End of view, please.
Yes.
Hold on. They want to
and
see the endoscopy picture.
You can see?
Can you give us the endo picture?
We do not have an endo picture.
Just a minute.
Yeah, this one.
What is the name of this?
Tornas.
So it's a longer retriever kind of a.
Oh, this is like a screw.
Yeah. Real screw.
And it's tapered also.
Real screw.
I saw that.
Real screw.
And it's got a screw.
Up to higher portion, and from here rotation. Only rotate, slightly push, but basically rotate.
It's so long.
Let's go.
You can really
rotate more rotate.
So who's the manufacturer of this? Which company owns this?
Olympus. Not me.
Wow. Takao, this is one unbelievable instrument.
Yeah, fantastic. So if Olympus people are there in the auditorium, it would be our request, I think, that please make this available in India as well.
But let's see how it is going in.
That's
very, very hard, tough structure.
You're rotating?
Yeah, it's rotating.
Rotating.
Yeah. But now you have to pull the wire also at the same time.
Yeah.
We tend to use a 6-French cystotome here very often, if in this kind of a tight stricture over a wire. That also works pretty well.
Yeah. Pull the wire and rotate at the same time. Only then it will go. Nagi?
Very tough.
Okay, for a minute we are shifting because Dr. Nageshwar Reddy is starting on another case.
A 65-year-old female nil comorbid illness came with complaints of pain in epigastric region associated with nausea and vomiting intermittently since 3 to 4 months. MRCP was suggestive of multiple calculi in the entire length of CBD. The CBD was dilated in its mid part and mid bipolar HBRD. ERCP tried outside, suggestive of multiple filling defects in CBD, failed CBD clearance, planned for ERCP stone removal and stenting. This is the MRCP image. Dr. Nageshwar Reddy, you are live.
Thank you. So this patient had an MRCP outside elsewhere, and I think they did some sort of a cut, probably a pre-cut to try and get in. So one of the issues in this patient is an anatomical difficulty of getting a scope. And you can see my scope position is fairly straight here. I'm trying to push it to get a better scope. And to help me with this case is Dr. Eli Aguti from Kenya. He's an expert in ERCP, and we're fortunate to have him here today. So we are seeing some bile-stained tissue there. So what I'm doing is I'm using the standard sphincterotome. This is clever cut sphincterotome along with the Terumo wire, and we'll see if we can selectively get. So what happens is when they do a pre-cut, sometimes they go into a false plane, and they have to be very careful that you get selectively into the bile duct. So now can you pass the Terumo wire slowly? Slowly. Let's see where it's going carefully. Yeah, so we are going up now. We're going up. Yeah, that's a good direction. Keep it like that. Keep excellent, excellent. See, we've gone now very deep into the bile duct. I think you can see some air cholangiogram also there. Very excellent. So we have some very good assistants. I think Amit has developed a big team now who are very good in assisting. So what we'll do is we'll exchange this wire for a straight wire, and you can see what happened in the other unit. Why they failed was after they did a cut, they lost the planes and they were not sure whether they're going to a wrong plane. So this is very important that you wait for a few days, and then when you see bile, you go in with a soft terumo wire, usually an angled terumo wire, and very often by choosing your plane very carefully, you can get into the duct. In this case, you can see now we're deep inside. Now can you inject contrast? And you can see that I'm injecting contrast right from the top and coming down. My scope still is not in a very optimum position, but this is good enough. Yeah, keep injecting, keep injecting. I can see a stone, multiple stones there. Yeah, multiple stones. But I think this should be out with a balloon. Yeah, there's a large stone. Can you see that?
Yes.
Yeah, very well, very well.
Yeah. So what?
If one has made the false track with the guide wire, what are the tricks to get into the right axis?
Yeah, so it's very important that you use first terumo wire, use an angled wire. Your probing should be done only with the wire, not with the catheter. Now we'll do a balloon dilatation. And then afterwards, it's also very important that when you have a doubt, inject small amount of contrast to see where you are. So these are the important principles. So what I'm going to do now, I'm going to use a balloon. Can you push up the thing?
Nagi, how will you choose the size of the balloon here?
Yeah, in this case the duct is very large, so I'll use a 15 millimeter balloon. So I think this has already been shown, so we don't have to discuss too much on
so
this.
Nagi, you are going to cut a little bit more? Cut a little bit more or no, not required?
I think it's not required because
required,
they already
no?
cut there.
Yeah,
I'll go directly with the balloon.
Better.
Because we can do a 15 millimeter balloon in this case. In fact, it's important to do that. What is very important in this case, again for those who are starting ERCP, is that if you see the stones there, they're going right down. So I want to push these stones up using a partially filled balloon and then complete the balloon dilatation. Otherwise, you'll crush the stones against the wall and chance of perforation. Amit? That's the plan, Amit. So again, you'll see my scope position is not very optimum. That's the reason why they had this difficulty in other units, because you can't get the standard J-shaped scope position in this.
So Nagi, we are quickly shifting to that room and coming back to you until you pass the balloon inside.
Sure. So I'll do that.
Shift to Rangsan.
Oh, okay.
Rangsan, we are with you.
Okay. Since you're gone, we have done, somewhat fragmentation of that stone, and there's still some, fragment that we think is small enough, but it's just at the 6 o'clock position, which is the blind spot for the laser in general. Okay. So what we're planning to do is to, fish it out with the spy basket.
Oh.
But I mean, the rest of the fragment, has been,
In pancreas, we have to be a little careful because these stones are very hard.
Yeah.
And if the basket gets stuck,
I see.
Then we can be in a little bit of a trouble.
Yeah, we're gonna try that. Is it not moving? We're gonna let it go and do more fragmentation.
Might as well flush it, or just place a stent for now, and then we see later.
Down. Okay.
And this spy basket is a very flimsy instrument, so it can't be used for any mechanical lithotripsy or anything. So if it gets stuck,
to fish it out. Yes.
Yeah.
Back. I think we almost.
But I think you have pulverized it so much that fragments seem to have come out automatically. Right. It become empty.
Another option, as I mentioned to you, but it depends on the cost, is to put the short, fully covered stent to let it drain.
Agreed. But Rangsan, you have done a fantastic job because we are struggling with this case for last so many years, and you did it in 10 minutes.
Oh, it's how we did that.
How we did it. So that is the Thailand team, no?
Thank you. This is our Songkran holiday. We got to throw water to the rest of them in this room after this.
So we will shift back to Dr. To Ichoy.
I think
let's go to Takao. Takao has been able to dilate that tight structure.
Yeah. So hard, so tough structure. Unless we use this new type screw dilator, may be impossible to.
It is a fantastic screw, sir. Meaning, The way it, yeah, it's really fantastic.
What is the diameter of that taper and the sheath of that screw?
I just need to see the cover.
Yeah, okay. And so easily, so we can get the right side here.
What is the diameter of that?
7 French? 7 French.
7 French.
Even the tip is 7 French?
7 French.
The tip
Tornus.
may be a little bit
2.6.
narrow.
Yeah, yeah.
2.6.
Yeah.
Superb.
I stay it here.
And now he's also cannulated the right duct.
Oh, you already gone in the right side also?
Looks like the right posterior probably.
Yeah.
Can we see the air cholangiogram now?
Yeah. That's what we were waiting for.
Please.
Once we came
Okay.
Yeah, yeah. You can see. Beautiful.
Beautiful.
It's communicating. And it's
Picture.
communicating.
Picture.
This is communicating. So 2 stents should be enough,
Yeah.
right?
Yeah, yeah.
Right.
Okay.
Yeah, 2 stents is enough.
Okay.
The left is also filling up now. After
So
the
you'll put
dilatation.
stent by side by side stent.
Side by side stent.
So you're going to use wall flex or wall stent from Boston Scientific?
Either is okay. So
Either?
which is your preference?
I think,
Wall flex.
you know,
Oh,
you can use
it's
the
much
epic
better.
stent probably. I think
Wall
the
flex
epic
is
stent.
preferable.
Yeah, the
Okay.
epic stents.
Okay, fantastic. Okay, let's go move on to the stenting.
For right
Now we are
side-
again going back to Dr. Nageshwar Reddy because he is ready with the balloon sphincteroplasty.
Yeah.
Hi, Nagi.
So hi Amit. Amit,
Hi.
actually we did the balloon sphincteroplasty.
Yeah.
And you can see some fragments are actually also coming
Already
with the balloon.
coming out.
But you can see the large opening there.
Yeah,
we can
yeah.
probably drive a truck into this now.
You can actually look inside the bile
Yeah,
duct.
bile duct. So what I'm going to do after this is I'm fairly large sphincteroplasty up to 15 millimeters.
Yeah.
And the stone size is approximately that. So I'm going to use
Yeah.
a new balloon
Yeah.
called the capture balloon,
Okay.
which is 5.6 French at the tip.
Okay.
It's got a 7 French shaft. It's
Okay.
quite sturdy, and hopefully we should be able to clear this with this. So again, showing you the angle, which is a little different from what we normally do in ERCP with.
Yeah.
But it's important to keep adjusting your right and left. Ali also agreed with the plan, what we had. And you can see this is the balloon that I'm using. It's a strong balloon with a tapered tip of 5.6 French. Yeah.
So actually, this patient was tried outside by another gastroenterologist,
Yeah.
and because they almost referred to a surgeon, and then they said, "Would you like to try?" I said, "Yes, we are getting Dr. Nageshwar Reddy today, so better you send the patient here."
Thanks for that.
And you have justified it.
Yeah, inflate. So what I'll do is I inflate lower down to get the lower fragments first, and then start. Now go up further, up. So we can put in some contrast also here, but also we'll inflate and then see some, little contrast. Okay, yeah, now there are a lot of fragments which you can see. Now inflate, okay. So we can see all this contrast coming out.
Wow,
also.
wonderful, wonderful.
Yeah.
You also pulverize the calculi.
Yeah, to
Nagi.
some extent there are softer calculi. Now we go on the top, right on the top. I think this is a very nice balloon from Madura that we're using.
So Nagi, for how long you keep the CRE balloon inflated? 60
so
seconds?
60 seconds. So you see that? One more. You can see like it's sometimes after you remove all these stones, it looks like a colonoscopy. So can you...
Fantastic job, Nagi, fantastic job.
So
You have made our day. And now we are waiting for you for the oration. So we are going to whisk you away back to the hotel.
Thank you. So you see now it's cleared completely. The CBD is cleared. You can see the
Great.
air cholangiogram, and I think should be
Our boys will put a stent here.
Yeah, okay.
You can hand over the scope to somebody.
Okay.
Because you will have to go to the
I
hotel
know, yeah.
for the oration.
No, but I think it's clear also completely. There's
Yes,
no problem
yes,
now. Thank you, Amit.
Thank you, Nagi.
Thank you.
Great job. We go back to Dr. Itoy now.
All right. Okay,
Takao.
welcome back. So already we advanced the dilator, balloon dilator for both side dilation.
Already done dilation?
No.
Now pass the balloon now.
Now is a LAM balloon.
Okay.
Over the wire type and
What
a very thin tip. Maybe after the screw dilation.
So this is also your balloon from Japan?
Yes, this
The Ren balloon.
Len balloon. I also stay this here.
What balloon is that, Amol?
This is called the Ren balloon, REN.
REN.
So Takao, when are you starting your own company?
I hope so.
Pankaj, those were the only 3 letters I could read. Rest everything is in Japanese.
Okay.
I'll be happy to take a job in your company as a marketing manager.
Okay. So let's. So
4 mm or 6 mm? What is this diameter?
I think this one was 6, I think. This one was 6.
6 millimeter. Yeah, 6. Yeah.
So, Dr. Amol.
Yeah.
So, for the right system, is there any preference for right anterior, right posterior? Or anyone which wire goes, you will go ahead and put a stent in that?
See, actually, Pravir, is it?
Yeah.
Yeah. So, you can use, place the stent in either duct, but preferably you should have a duct which is straighter so that your wire goes in deeper and there is no less angulation, so that the stent opens up and remains in the configuration of the duct. So
usually
usually we would use the right anterior, but sometimes you have to go to the right posterior because if the angulation is different.
Yeah, I think, Amol, that is important because you have to have a straighter axis for the stent.
Right. And sometimes otherwise,
Amol, what is the Monia?
Yeah.
What is the like significance of this red balloon when compared to other balloons which we
it provides a very nice dilatation because I think it's very tough. It's a very tough balloon and gives a very good dilatation. So I think the material is is much stiffer than the Hurricane also. That's what I think. Am I correct, Takao?
Yeah, correct. Yes.
And what stent you should put first, left or the right, Amol?
Let's ask that question to Takao. So, Takao, which stent would you like to place first, right side or left side?
Basically, the difficult, firstly, difficult portion, difficult angulation.
Yes.
Usually, if we place 3 stent, firstly the posterior and the left side, and finally anterior. That's why. So this is in this case is the left side first, and then anterior. Yeah, right.
So the more angulated and difficult side should be approached first.
Yeah.
I think that is a very important message. You always put the difficult one first.
So finally, we dilate anterior.
Another thing which we have noticed is if you use the RX system of stenting, sometimes it
buckles.
Difficult to pass through tight angulated strictures.
Right.
So I think I think for if you are using Boston stents, it is a 10 centimeter stent which has an RX system.
Maybe
the others are
you have to pull the wire on the right because it is getting looped. Looping.
Yeah,
wire.
Maybe we have to just reposition the wire a little in the straighter duct.
The right wire also needs to be pulled, right?
Yeah.
Dr. Amol.
Yeah.
Within the fact that US HGS is an option if you are unable to
great.
Very nice.
drain the left system.
Very nice. Readjust. Okay. More. Okay, good. Okay.
So does it make any sense to
direction?
Deploy the right anterior first so that even if you are not able to stent the left system, you are able to do an HGS?
Yes.
Yeah, that is a point, Pravir, but here after the dilatation and with the 6 millimeter dilatation, the chances of not being able to stent the left duct is very less. So if we had not gotten access or even after the dilatation, if your stent doesn't go in or kind of buckles, then probably you can do that. But otherwise, left being the more angulated one, you put in the right one, then you may lose an opportunity to stent the left side, despite everything else.
So Amol, for how long we should keep the balloon inflated? He is doing it repeatedly.
How long?
Yeah, so different levels. Usually, I think 30 seconds is more than enough. But if it's a very tight stricture, sometimes you can go up to 1 minute. There are no guidelines, very clear guidelines as to the timing of how much the balloon should be inflated. I think each one of us has our own thing, and very often it is also determined by the number of procedures which are pending on the day.
I want you all to see what he is doing. As he's coming out, he's dilating the CBD also.
The bile duct also.
Yeah.
And Amol,
you
and between you, Takao, sir, What is your take on deploying one after the other stent and deploying two 6 French assembly stents together? What is your preference?
So, Pankaj, alongside stents, whenever possible, I usually tend to prefer them. We use the Hanaro stents or the Epic stents alongside each other. If that is not feasible for some reason, it's not available, the length is not suitable, something of that sort, then side stent is another option. And also, stent in stent as a Y kind of stent, or that is also a third option. So
fantastic job, Taka. Go ahead. Now you can place the stents.
Okay. So that's
Professor Itoy, would you use RF ablation before placing the stents? Radio frequency?
I rarely use this technique. Just stenting, in particular, in case of a side-by-side using a fully covered metal stent, I don't use. Okay. 8 centimeter. The maximum 8 centimeter. Okay.
So you're using Volflex 8 centimeter?
Yeah, Volflex 8 centimeter.
Okay.
Or 10 centimeter. 10 cm much better. Much better.
Okay. So this one you can use side by side also, both the stents.
Yeah.
This is 6 French delivery system.
6 French, okay. Good.
You can even pass both stents simultaneously and deploy.
Difficult, right? So of course the Jiruba or thinner metal stent is possible, but 666 impossible.
So you're using 10 centimeter?
10 centimeter, yes.
Also use a 10 centimeter stent.
Yeah.
Both 10?
Both 10.
Oh yeah.
Okay.
Epi, but works then, no? Epic stent. Epic stent.
Epic stent?
Yeah.
Yeah, okay. Laser cut, 10 cm. How about it? Either is okay.
I have a feeling that Epic stent, once you open, passing another stent by the side can be difficult because it has got sharp edges outside.
Yes, I think so.
So better you put a normal Volflex. Don't use Epic.
Epic, if one has to put, I think it is better placed side by side.
Yes.
Rather than one after the other, because otherwise it can become difficult to pass the second.
Absolutely true, Dr. Mahadev, because Epic stent and the silver stent, you have to deploy both together.
Yes.
You cannot deploy it one after the other.
Yes.
Never.
So.
This is 8 centimeter.
Yeah. Only the Wolfrex only we have. You have 8 cm. 8 cm.
So
you have
10 centimeter.
Oh, if so. Yes, Wolfrex and 10 cm. Yes, it's much better.
Let's use Volflex 10 cm.
Yeah. I didn't saw.
You thought it is not there.
Perfect. Yeah. Bona. Bona is also nice. We frequently use 10 cm. No, Wolfrex is much better. Yeah. So how about the fully covered metal stent side by side?
Fully covered?
Not fully covered, uncovered.
Uncovered.
This time uncovered, but we sometimes frequently use as a large bore plastic stent imaging.
Okay.
Other 6 millimeter in diameter, fully covered.
Yeah.
Side by side.
Okay.
We sometimes use like a large bore plastic stent.
Correct.
Easily remove. Removable. But this time it's okay.
We've hardly ever used fully covered stents. The only time is post-transplant strictures or post-cholecystectomy strictures where we use the Kafi stent. But that is a short 4 centimeter covered.
I think.
But you don't see any migration with
No. Usually no. Tough stricture, no.
No, but even with tight stricture, sometimes after 2-3 months you will see that the stent has fallen out. That's the.
So
even with an intact gallbladder, would you use fully covered stents?
Fully Jose gallbladder, X-ray, push.
Dr. VGM, I think if the gallbladder has not been filled up during cholangiogram, I think the risk is not too great. But if it fills up during cholangiogram, then probably chances of cholecystitis are higher. That's our thought process.
So many talk. We have to take care of the guide wire by myself. Okay. Slowly, relatively hard. How to see?
Okay. Can you enlarge the floor?
No. The positioning of the scope is also difficult in this patient from the beginning.
Professor Itoi, what is the difficulty in pushing the stent deeper?
It's a little bit of an angulation.
Angulation, yeah. And very hard because
I'll tell you another difficulty. This is a 190 scope.
190 scope.
Yeah, sometimes because of the V of the elevator, that causes a lot of friction between the stent and the V.
Yeah, exactly.
So you open the elevator and then we just push the big wheel near. Or slightly in a long loop position. It's the V which is causing the trouble.
So the stent is already
the plastic gets stuck at the V.
It's gone in now. It's gone in.
Yeah. Gradually, the tension. Yeah. Guide wire.
I think the slight long loop position helped us.
Yeah, just pushing the scope in and correcting the direction.
Going. Now is the trick. You
guide
have to
wire.
push the wire inside a bit.
Yeah.
Because the soft portion of the wire is at the angle.
Yeah, exactly. So not over the wire, that's why so sometimes very difficult.
Yeah, the problem with the wall flex is that only because of the RX you cannot give adequate counter traction. So that is the biggest challenge.
Because of the RX?
Yeah, because of the RX.
RX is an issue.
Yeah, RX is a major issue.
No. Maybe too much. ここで反転しちゃってんじゃないの?
Oh, the wire is coming out.
ちょっと待って。ちょっと押してて。Take care. So lower side. Yeah. Papillary side. Still okay.
Still not taking the turn. Yeah.
Now the wire is gone.
Now the wire is gone.
Okay.
So Amol, in these cases, should we use a tougher wire from Cook or something else? This is VisiGlide, I guess.
Yeah.
VisiGlide
is
I'll tell you.
Tough. It's the problem with the RX, I think.
The stiffest wire we have is Dream Wire from Boston.
Right.
For ERCP.
So tough. The angulation.
So Dr. Maitha, you think changing to a Dream Wire might help here?
Yeah, one is changing to Dream Wire, and if required, change to a non-RX system.
Yeah, that I would agree. Non-RX definitely, I think.
Yeah. Loop. It has got looped.
Very difficult. Right?
Virus come out.
But even guide wire
again gone in.
But I guess angulation is very tough. So one option here is a plastic stent, and the other is a metal stent. Yeah. Otherwise, I guess again. So we try, but very tough.
Another stent, maybe a Korean stent might be better here.
Yeah. Sina. Yeah. Oh, okay.
Dr. Amol.
Bona.
Dr. Amol.
Over the wire.
Yeah. I think if we avoid the RX here, then it will be easier.
I think that is a...
Can we dilate more?
I think a 6 millimeter dilatation is
dilation
as wide
up
as you can
to
get.
6 millimeter.
Anything more than that, how much are you going to dilate? It's the angulation rather than just the stricture tightness.
So what is your plan now? You're going to put the bona?
Yeah. Trying to put the bona. We'll try putting in the bona.
The bona is 10 centimeter?
Yeah.
So both bona you will put?
Again,
or there will be a marriage between bona and wall flex?
Then
that could be possible, I think.
Again, so we need balloon dilation.
You know, the Boston stents are very good for their radial force, but because of their high radial force, they are a little bit less compliant. And because of that, the angulation, they take the angulation less. The Korean stents are probably a little less on the radial force, but because of that, they are more compliant. Many.
Okay, we are quickly shifting to another room.
Okay.
We are quickly shifting.
A 49-year-old male came with nil comorbid illness, history of post-cholecystectomy bile leak, came with complaints of recurrent episodes of fever, abdominal pain and jaundice. CT showed a filling defect in proximal CBD with upstream dilatation of CBD, multiple ERCPs and stenting done outside with failed ductal clearance, planned for ERCP with spike cholangioscopy and ductal clearance. This is the MRCP image. Dr. Thawi and Dr. Rungsun, you are live.
Good morning once again. Thawi, go ahead.
So we come back. You can see this kit. Today I use Fujifilm 5XT. X1 is a new one. It's more ergonomics.
Can you tell them a little bit why we put the patient on left lateral?
Because in this patient we plan for the spine. As you know, it's if spine in supine position, maybe less of the aspiration. So recommend in prone position or in the left lateral position.
We look at the previous cholangiogram. We found although stone is not big, 1 cm, but it's hanging there at the common hepatic duct.
Right.
So this probably distal system is relatively rather small. So I think for this case, it's not a good candidate for balloon plasty. So I think it's better and go ahead with probably this is some type of Mills syndrome. So we plan to do spine guided laser lithotripsy.
You can see it's on my hand, a little bit in this position is the form scope, and same when you use in the supine in the prone position. Okay.
So let's check cholangiogram first.
It looks like the Mills syndrome.
So this day, I think Amit, you are the one who is a pioneer on treating Mills syndrome with endoscopy before we have this scope. So it's quite difficult, but this day I think this is kind of normal routine that when we see this kind of thing, the first attempt must be with cholangioscopy.
Right. We try to negotiate with the guy wife first. We just touch the opening.
Yeah, can we have if the
Follow
picture
please.
bigger?
Yeah.
Okay, can you enlarge fluoro view? Yes.
You can see it's a wide view. Right now the wide. You can see the clip post cholecystectomy. Good job the wide in. Yeah. I slowly put the catheter up. You can see right now my catheter tip at the hilum. So start inject. Yeah. So let's go. Okay. You can see right now the stone maybe is behind
the scope.
The scope. So we need to change a little bit the patient to the prone position.
Can you rotate the patient on prone, please? Or the other option is to rotate the C-arm, but I think because of the risk of aspiration, we found that prone position may be better for them to control the airway in terms of suction.
Okay.
Can you see the stone now?
Yeah. Can you give a bigger fluoro?
Yes.
I'll put the
right
patient
now
on
we
prone.
try to rotate the follow.
But it does not show.
Not in the center.
Very clear.
Yeah.
But yeah.
So you can see stone.
Yeah.
Okay, now we can see with this rotation.
And you can see the the below the stone is a small bile duct.
Yeah, narrow duct.
Yeah,
Narrow
that's why the cannot remove with the conventional.
Yes, yes, yes.
So maybe the good candidate for the spy guided.
I think two options in general. You can use microlithotipter to cut, or you can use spy to break with the laser or ESL.
So Thavi, in these situations, do you prefer a cholangiogram in the, slightly in a better angle so that the bile duct and the cystic duct are separated from each other and you can get a better angulation?
Right, you're right. Because in this case, previously suspected a stone in the cystic duct and drop down, but you can see the clip close to the common hepatic duct.
Right. Because if it is a cystic duct stone, usually mechanical will not work well because you can't grab the stone in the basket very well. So that is a problem.
Right, you're right.
You have to resort to laser. If it is in the CBD, then we can still try with mechanical.
So I think this stone in the common hepatic duct. So I think it's good for you to show how to break with the spine square.
Yes. Yeah.
Okay.
Yeah. Wonderful.
I think maybe big enough. No need because the stone is not so big.
Right.
We can direct cannulation.
Okay. So you're not going to dilate?
I think previous swingtomy is big enough. So we try first.
So we can do we can do a backload of the laser, and he can do freehand cannulation. So we will show you how to do freehand cannulation with the spy scope. So let's do the backload with laser probe first. Can you load the laser probe?
Can we have a bigger fluoro image so that we can see the size of the stone?
So with this, as we mentioned, similar to previous case, when you encounter resistance, by the time if you're not doing backload kind of thing, if you do it after, you have to pull back the scope.
As you are getting your spy scope inside, we will just go to another room. Dr. Ivo Boskovsky is starting another case.
Yes.
So let's have the history, please.
Yes, please.
41-year-old male, nil comorbid illness, came with complaints of abdominal pains in 6 months.
Put a clamor here, please.
With no history of jaundice or fever. CT was suggestive of intraductal narrowing with hepatolithiasis and hilar stricture.
Both
PTBD was done to RPSD with multiple hepaticoliths and LHD. Now planned for spy laser lithotripsy via PTBD. This is the MRCP image. Dr. Ivo Boskowski and Dr. Simon Loh, you are live.
Hello, hello. We have
Hello, Ivo. Yeah, we can
again the excellent team here, and with a great help here. So this is a young boy with IgG4 cholangitis that has 2 percutaneous drainages. We just injected some contrast above, and I was supposed to do percutaneous spyglass and lithotripsy of the stones, but if you see that MRCP that was done in February is completely different from what we see at cholangiography here. Why?
Can you have a larger cholangiogram here?
Yeah, you can show the cholangiogram, please. Go up, and we can inject from the right. We can inject from the right. And what happened? He's on.
Can you reduce the KV a little bit?
Yeah, he's on corticosteroids, so the stricture changed dramatically. So this is a young patient, and I think if we do percutaneous spyglass, we need to dilate with 11 French dilator to go in, and that hurts, and then you're obliged to place another percutaneous drainage for any serious adverse events like bleedings and so on. So
you're planning an endoscopic transpapillary approach?
Yes, because we inject it also from below, and the stricture seems almost solved. So I think we discussed here together. We think that the best thing for this patient now is to dilate and place 10 French stents left and right, and then dilate the stricture from below, continue corticosteroids, and then remove the stones on short term. And not to do it from the percutaneous side.
Right.
I mean,
it's really not necessary.
Yeah.
Yeah, I agree.
Yes, so you see now injection from the right. Look.
Yes. Can you give a bigger cholangiogram and maybe a smaller?
So contrast goes from left to right without problem.
Yeah.
You see, and goes downstream. So that what you see there is 8.5 French percutaneous drainage, we will do some dilation. If there is space, we will try to remove some stones, but the stones are not the problem of this patient.
Yes,
it is the disease that is autoimmune cholangitis.
Right.
Okay? So now...
Do we have histological evidence of
yes.
autoimmune cholangitis?
Yes.
Yeah, the patient has been treated with 1 or 2 months of steroid.
So
and it's been stopped.
do you have a snare to catch the wire?
We need to continue the steroid as far as we're concerned right now.
Can you give me a snare?
Okay. So by the time you get the wire out using a snare, we will just go to
it's okay.
to Thavi's room and see. They've, I think, localized the stone. They're ready to fire. Okay, Thavi?
We use we use freehand cannulations by Professor Langson is the big wheel up and then kissing and then put the spike in. Right now you can see on the screen.
Yeah, we can see that.
This is the stone.
Yes.
So so Langson will break with the thulium laser.
Very soft stone compared to the previous magnetic stone we have. See that?
So it's going really. You know, this thulium laser is something which is fantastic, meaning the power-wise, I think it's much superior to the holmium. And the way the stones fragment, it's really very nice.
You can see Langson move around and to keep a little bit.
I'm painting, putting my name here on the stone.
Langson.
So the clear view is very important to break stone. You need to see the laser fiber all the time.
Yes.
If not, maybe you create bleeding or perforation. So you need to adjust the volume and aspiration.
So Thavi, for just for the benefit of the audience out there, those who may be a little bit new to laser lithotripsy,
right?
How much of the laser fiber should be out of the scope to get achieve a good fragmentation control as well as no damage to the spy scope?
You can see the boot sheet. Boot sheet is very important. Normally you get boot sheet 5 mm from the tip of spine. If you not put it less than 3 mm, it's a heat. Maybe you broken the spine.
Yes.
And you cut the small tip. As Professor Amit told you, the laser is 400 cm. You can cut every time when you use it.
Yeah, so that's an important takeaway for those who are embarking on SPY and laser lithotripsy. You should always see this blue tip.
Right.
And don't just rely on the green guide beam.
Right,
because
you're right.
That you might still be able to see even when your fiber is inside the scope.
Yeah, because SPY is really expensive right now. But you can see the effective of the SPY combined with the thulium laser. This is also the first time for me. My unit normally we use SL and holmium laser.
Yes.
It's quite good.
No, I think it's quite good, and probably thulium is the way to go in future.
Amol, again for the beginners, would you clarify where to start breaking the stone? Is it better to do it from the periphery, or is it better to start in the center?
Normally, I recommend you start in between central and periphery. That's a good point. And then you slowly, not start in the center.
Usually you would...
Yeah, you start in between, yeah.
Urologists, when they use the electrohydraulic or laser, they start from the periphery. They feel that periphery stone is little breakable easily, and then they come to the center. I don't know.
So there are basically two ways of fragmentation. One is to chip away the stone bit by bit, and the other one is what Avi is doing over here, is to blast it completely and pulverize it. So these are basically two different ways of, two schools of thought, I would say. And each one of it has its advantages. When you do it chip by chip, the fragments fall off. In urology, they do it more often because they don't want the fragments to go proximally into the renal pelvis. But here, usually we are going to, follow this up with a stent. So it's not that much of a big deal, and that is there.
One publication from the urologist to show it, compare the static, putting the laser fiber and moving around. You're moving around is more effective to break stone. So not static, the laser fiber, you just move around.
I think we are seeing a very effective fragmentation.
Yeah, now
right.
Very good.
Very effective.
Very well now. Another thing they do is a technique called holding the stone in the basket so that the energy will not displace the stone away.
Can we have the, who is moving the spy? Is that Rangsan?
Rangsan, yes.
I'm the co-pilot.
Okay, so
Power breaking stone, two main techniques is fast and easier.
Shubhata, can you just move a little bit so that we can see Rangsan's hands over there?
So I'm moving the small
and zoom in over there.
Of the spy scope,
Down
left
and zoom.
right. It's like I say that it's like I'm painting.
So Rangsan is painting with the spy now.
Yeah.
Exactly.
So in the BC center, that you only one doctor to do it. You can fix a spy scope at the handle of the ERCP scope, and then you can hold at the conventional, or you can hold at this level to control the spy scope and ERCP scope at the same time.
Right.
Amol, yesterday somebody told that you dig a hole in the stone and then pass a balloon and break it if it is a very large stone.
That is a little bit, I think, see, there are various ways to skin a cat, I would say, but boring a hole through the stone and trying to get a balloon through and expecting the stone to fragment the stone is really little bit, I don't know, it may be possible, I have never tried it, I have no experience in that.
Amol, the balloons are so flimsy, they'll just break.
I know, that's what I feel, but I have no experience in that. Let's move to Takao. I think after he's changed the stent, he's using another stent, he's also got another wire in place, so let's see what he's doing. Takao, we are with you.
Yeah, so
welcome back.
I can see you, although I'm not standing behind you.
We change the left side guide wire to the good position.
Oh, that is good.
Now is good.
In the meanwhile, we changed the wire in the left system.
Yeah.
We dilated a little bit more, and we confirmed the position by injecting some contrast into the left duct. And so now
what is the wire that you are using now in the left system?
We are using the Boston 035 Dream wire.
Okay.
Dream, yeah. So Ankit, how much dilatation we have done now?
Again, same 6 millimeter balloon only, same, but we just repeated the dilatation.
And so
Takao, which stent are you going to planning to use? Go back with the Volflex or use the Bona?
No, we are using the Bona now.
Bona.
Okay.
10 centimeter.
Right.
Still hard. I guess it depends on the scope. So now it's very tough. So how much size of this scissor? How much French? Seven
French.
7 French. Okay. Okay, now going.
Yeah, good.
Wow, excellent.
That is amazing.
Yeah.
That's very good. It has walked in. Great. Wonderful. So Takao, amongst the three things that you did, what made the most important difference? What do you think? Is it the wire or the repeat dilatation or changing the stent?
I think dilatation. So otherwise, so no device is advanced. That's structure. Okay. Now open.
So the important takeaway is if your stent is not going across, pull the stent out, dilate again.
Yeah.
Get a position of your wire reconfirmed. It's going to be a little bit longer.
Okay, now, so gradually open.
Fluoro big, yeah.
Bigger, fluoro. Okay, good. Oh, very much to the bile duct. Okay, go back.
Dr. Amol?
Yeah.
The structure was so tight, so what is your plan? To put the parallel two stent and release simultaneously?
Yeah, here. Okay.
No, I think Takao is planning
one
good. Stent after another.
You can see.
Probably I might have preferred putting two stents side by side in this kind of a situation, just to make sure that we are going to be able to get both the stents in place. It's more of a kind of a safety this thing, but of course Takao is Takao.
Yeah.
And I'm sure he's going to be able to get the second stent in alongside.
So you can see endoscopic imaging and so yellow marker. Stop.
Yeah.
Yellow marker? Yeah.
Yeah, so that yellow marker is very important.
Yes, here. Yeah. Okay, gradually open. So first stent. Okay.
This is 10 centimeter long?
It's a 10 centimeter long stent.
Keep the endoscopic picture PIP.
Fluoro.
Okay, first stent, open.
Now, Takao, how quickly do you want to put the other stent? Because that is always a concern. Because the minute you've deployed the first stent, your clock starts ticking now. Because, if you struggle more than 5-10 minutes, progressively the procedure becomes more and more difficult, and the chances of us being able to get a stent in diminish exponentially. That is what I feel.
So another guide wire you can see. Okay.
Yeah.
Okay.
Stent. Which one? Bona?
Which one?
Same.
Bona, same.
Yeah,
Same.
okay.
Same is this Sina and very nice. Okay. Another one. Do you have another Bona? Okay. Yeah.
I think it's always better to preload on the other wire, keep it very close to the endoscope.
Yeah,
the moment you deploy
we usually would do that, meaning it's, Takao will just go to Evo's room and come back. I think Evo's just...
Oh, really? Oh.
Yeah, you can advance the stent until then, not a problem.
But Amol, we would like to see the stent.
Yeah.
Push.
Yeah.
Fluoro, please.
Oh, yeah. So next one here, you can see gradually after sphincter tone. Maybe not easy to go in the guide wire. Okay.
It becomes difficult once the first stent has opened up.
Any tricks?
One is match the axis.
There's a bit of an angle over there, which is making, difficult to get the stent across the papilla.
Okay.
Yeah, now
Okay.
Now it's in.
So now we match the axis of the first stent, and so across. Yes. Maybe it's okay, and so to check the yellow marker.
You got a
Maybe
big round of applause,
Professor
Ito.
Yeah.
Hear the applause.
Yeah, we could, of course, hear the applause.
Okay.
Great dexterity and hand skills.
So second stent, so not easy fully deploy, but so later, a couple of days later, usually, so fully expansion.
Okay.
That's why. So firstly, second stent is usually longer. Okay, let's see. Oh, open. Very tough. So thanks to bonus stent. So John's nice suggestion. Yeah, endoscopic marker. Now you can see. Endoscopic marker, yellow marker. Okay, let's go. Guy. Yeah.
So Takao,
yeah?
Usually we try to keep both the stents at the same level so that in case we have to recannulate these stents, it becomes easier. So what is your policy about that? And how strict are you about keeping the distal ends of both the stents at the same level?
And
he's asking whether you place the stents at the same level?
No. A little bit longer, basically, but fortunately, so almost same level.
Yeah.
Almost same level.
Okay.
Happily. Oh, okay.
Fantastic. So Takao, we are going to leave you for, now. Congratulations, fantastic demonstration, but we'll go to Thavi's room now because Thavi is ready with his case. Yes.
Okay.
So thank you so much. Thavi, we are with you.
Yeah, welcome back. After lesson to break stone with theorem, right now we can remove stone. You can see on the screen.
Oh, wow.
The stone already removed and full scope.
Tremendous stone load.
Yeah.
I think the patient must have lost a few grams.
Right. And cholecystocam is right now completely clear.
Lights become easier after the laser and cholecystoscopy become a
Wonderful.
Okay.
Fantastic. So would you place a stent here, Javi, or would you not place a stent now that the duct is clear?
Basically, if a brick stone with the spine, normally we put one stent.
Yeah, and how long would you keep that stent?
We let a patient come back on 4 weeks, 1 month.
Weeks.
Yeah, to check.
Okay.
Yeah.
Yes, because this is important because when we are fragmenting stones, we're using laser, the fragments can go into intrahepatic, they can migrate here and there, and so it's always a safe option to keep a stent.
And my practice also, after we break with stone, I already put a basket in and checking to irrigation to remove a small fragment. That's my practice.
Wonderful. That's great.
Okay.
So let's go to, thank you, Tavi, for this excellent demonstration.
Thank you very much.
Thank you. We will go to Ivo's room now.
Balloon.
Ivo, we are with you.
Thank you. So what we have done, we dilated in the left and the right, but there was no stricture. So we went to 6 millimeters, and the balloon was floating inside. So we think that the corticosteroids did their job in this young patient.
So would you want to do a cholangioscopy in this situation now? Just to confirm something of that
But
sort?
it's already confirmed histologically. If you want, I can do.
No,
but
whether the stricture is opened up.
I think really it's not necessary in this case. So what I will do is pass a Fogarty balloon just to try to remove some of those stones and to test the stricture. Inflate, please. Okay. Let's see if this will pass. You see? No stricture.
Wow. Inflated balloon has also come out very easily.
Yeah, very impressive resolution of the stricture.
Dilate.
With steroid.
Yeah, with steroids. Okay, let's check again. Inflate, please. This is full inflation.
Yeah, and with full inflation, the balloon is coming down quite easily.
Yeah, there is some stink inside, so it's doing some.
Is there some resistance there?
Yeah, but it's nothing.
Okay. So the stricture seems to have opened up. So
yeah.
So what would be your plan in this kind of a situation?
Since he had percutaneous drainages, I will place 10 French stents, however, just for safety, and then this can be removed afterwards. And with the checkup cholangiography. Fluoro, please.
What about a cholecystectomy?
What do you think? Should this patient do cholecystectomy? Okay, deflate. Okay.
But do you have stones in the gallbladder? Otherwise, what is the
there were stones before.
Yeah. So let's place, I suggest, 10 French, 12 centimeter on the left first, and then we go on the right.
So would you place straight stents or double pigtail stents? Any particular preference?
We'll place a straight stent that the assistance here pre-shaped for the left. You know, on the left, the anatomy is like this. Turns, so we will place, I will show you the stent. This is this one. Show me fluoro, please. Yeah, no, balloon. Directly with the stent. I will show you the stent that they pre-made.
Okay.
Can you give me the stent? I would just want to show it. Look, it was pre-shaped for the left.
Okay. Can you zoom in there? Zoom in. The external camera.
On me.
Yeah.
You see?
Okay. So, is it a 10 French stent?
10 French.
10 French. And what are the chances, Ivo, of these stents migrating?
Well, this is why we pre-shape. So we'll see if we can place 2 on the left and 2 on the right. Let's see.
Oh, wow, 4.
We need dilation.
That's ambitious.
We need dilation. So we'll see.
Probably not necessary.
I don't want to be too ambitious, of course. But I think it's enough to have 1 stent. But because the resolution is fine. Go. This is left. Let me check fluoro, please. This is left. Yeah. Good. Okay. What happens? You need more? Push. We are doing rendezvous, you see?
Yeah.
This is a long, stiff wire.
Yeah. So I think because of the rendezvous, I think two stents also could be a possibility. Only thing is you'll need to someone will need to pull onto the wire, the percutaneous wire, and then probably you'll get the traction to get two stents in.
Oh, just a second.
So are you planning to put two more wires on both sides or something of that
We'll see, we'll see. Let me just place this stents here and then we'll check. It will come, it will come. I close the elevator and it will come. Look. Going down, going down. These homemade stents are so nice. This is Teflon, no? I love this.
Yes, Teflon. They're very stiff and very nice.
So they pre-shape them.
It's shapeable also, right?
Yeah, it's very nice. Nicely shapeable. Something happened to my position. Show me, please. No, there is the wire. The wire goes out.
Amol,
okay.
When do you use plastic stents in malignant biliary stricture? Is there any role?
Fluoro, tell me when you have the wire.
For higher malignancies, if the cancer is operable, but you want to downstay, get the bilirubin down or the jaundice down, that is the situation where you would use plastic stents. Because if you use metal stents, then it's going to cause problems for the surgeon. So that is the time when you would use plastic stents. Otherwise, for distal CBD strictures now, I think the role of plastic stents for pre-operative drainage is practically not there now. There is enough data to suggest that short metal stents work better. That is how it is.
Yes. The flap, huh?
Yeah. It's not going out because of two wires?
Yeah, probably.
Could be.
Yeah,
it will.
Yeah, that's good.
Yeah. We need some bodybuilding here and good breakfast in the morning. Okay, I'm pushing like. Show me fluoro, please. Fluoro. You so? Yeah, because there are two wires inside and there is some friction.
It's the internal flap that is jamming the channel.
Yeah, first one is out.
It should be okay soon.
So Eva, what is the trick to get this 10 French stent out of the scope alongside a wire?
Good breakfast.
Probably the toughest question of this workshop, I think.
And strong hands.
Some vegetable oil or olive oil or something, it will be easier. Yeah.
Because now, since I dilated on the right wire, I have some friction there. Okay.
You're almost there.
Show me fluoro, please. Yeah.
5 more centimeters.
Thank you for encouraging. Okay.
So, Amol, which antibiotic and for how long you prefer in these all strictures before you take the procedure?
Thank you.
I think it minimum was a month, right? For the container track to close.
Yeah, we leave up to 3 months. Plus 6 stents. So our policy for post-operative biliary stricture is exchanges every 3 months. Show me fluoro. Okay.
Almost.
Okay. Little bit more.
Yeah.
I wanted to go to the gym, but I'm fine for today. Okay, it's out? You're right? Yeah, you're right. Okay. So please leave it like this. Yeah. It's done?
Yeah.
Remove the wire, please.
Yeah.
Remove. Don't worry.
Yeah. Excellent.
Okay, so slowly pull this because it is blocked with the wire. Hold the wire from the other side. Okay, give me the other stent. So this will be easier, I hope. You see aerobilia inside?
What length would you choose, like a 10 or 12 centimeters?
Same 12, again 12.
Okay.
We dilated up to 6, but this stricture is resolved. These stents are probably only to sustain the percutaneous drainage and to help outflow of the bile. Yeah. I think you can revise this patient in 1 month.
Yeah, exactly.
4 to 6 weeks, and that's enough.
Be fine, yeah.
Just to do some clearance of the sludge inside, and that's it. So can you show pre-shaping of the stent? Look, it's so easy to pre-shape this stent with the hands. Thank you, beautiful, beautiful. And they can also make it like the Soendra dilator to have a sharper tip to pass the strictures. I think this is very clever thing. We're waiting for the stent.
This is all teaching from Dr. Sohendra, isn't it?
Yeah.
We went back to the days of Miss training.
ERCP is so creative. Yeah. You can also invent your procedure.
Dr. Ivo Boskowski, thank you so much for the case, and we'll have to switch to the other room.
Okay.
Thank you.
You're welcome.
Thank you, Dr. Simon Low, and thank you, Dr. Boskowski. So for the last case, this is a 27-year-old male, came with, is a known case of chronic pancreatitis with EHPVO, status post lap cholecystectomy. Now came with complaints of epigastric pain, jaundice, pruritus since 1 month. MRCP was suggestive of changes of CCP with pseudocyst, long segment stricture in the distal CBD with upstream dilatation with IBRD, ERCP done outside, 2 stents placed in RHD and LHD, IgG4 of 4.94. Now planned for ERCP and spike cholangioscopy with biopsy. This is the MRCP image. Dr. Amol Papai, you are live.
Hello?
Yes, Amol.
Yeah, so I just got the scope in, and we're trying to still get to the papilla. Probably a little bit of edema in the duodenum, I'm still not sure why. Let's see. Probably because of the chronic pancreatitis and everything. This patient has a combination of a lot of things. Chronic pancreatitis, he's got EHPVO. Oh, the position is also seems to be quite tricky actually.
Amol, that is why the case was given to you, Amol.
So, more the position of the patient is supine, left lateral?
Patient is supine presently. I'm not sure whether I'm going to be able to shorten the scope completely. That's the papilla. It's quite bulky and bulging. Let's see. Can I get a fluoro shot, please, just to see the position of the scope? Okay. So you can see that it's quite an unstable position. I'm quite proximal over here.
Would changing the position of the patient give you more
stability? But we also want a good cholangiogram. So a good cholangiogram will be obtained only in a supine. So it's a trade-off. We'll try. Sometimes what happens is we might turn the patient lateral, get a wire in, and then probably turn the patient back. Sometimes that has to be done, but we'll see as of now. Okay, so can I get a wire and sphincterotome and wire? Right, thank you. So I have Shubhada over here to assist me, and you all have all seen her skills in the last 3 days. She's very good.
Why papilla is so bulky?
I think this patient has chronic pancreatitis. There is a lot of edema in duodenum. You can also see there's a little bit of pus as well. See there.
Fluoro, please.
Fluoro. Okay. So I think, do we want to take some bile for culture in that case? Yeah, we might want to take some bile for culture before putting in contrast, because so this patient has a hilar stricture, proximal stricture. Now we have to differentiate or try and differentiate between an autoimmune cholangiopathy versus EHPVO, because EHPVO can also cause a stricture. So although his IgG4 was elevated, that's not the only thing which we would go by to put him on immunotherapy. So that is what is important. Although the patient has received infliximab for ankylosing spondylitis. So Gaurav is here, he told me that. Yeah, contrast.
So Dr. Amol,
yeah,
this is a lower end bile duct stricture and we intend to do a spyglass. So how good is spyglass for lower end bile duct stricture?
Well, I think it's basically Dr. Amit trying to test my skills, because in this kind of a duodenum and distal bile duct stricture, trying to maintain your position for the spy scope is going to be very challenging. But when if you need to do it, you need to do it. So challenge is
I think only a surgeon can understand another surgeon's difficulty. Okay, Amol. So there is a request from the audience that the cholangiogram should be moved to the center of the screen, because the podium is hiding, so people on the right side cannot see.
Can we have the chain in
the fluoro image should move.
Give a bigger picture of the fluoro. If you can. Yeah, that's better. So it's not that distal either. It's mid to distal CBD. So that is how it is. So probably we can get a spy scope there.
So in the presence of such pus or purulent material, like how comfortable are you to perform a spy?
So Gaurav, I'm going to use a balloon to do a sweep before we put in the spy, because otherwise these patients can go into severe cholangitis post-procedure. So we'll put in the wire and then we'll just do a balloon sweep and then put in the spy. Fluoro? Right. Great. Thank you, Shubhada. एक balloon घे.
So how much you will dilate, Amol?
No, I'm not dilating.
I'm going to sweep.
I'm going to do a balloon sweep, because we saw some mucus plug and pus and all that. So we'll clean that up. It will also help us visualize better and also get the duct cleaned up a little bit before we instill a lot of saline. So that is important. And the third thing that the balloon will also do is it will actually tell us the level of the stricture and how tight the stricture is. So that, sometimes you just have to push with your spy and that becomes difficult. You're not sure as to what where you're getting into. So a little bit of calibration of the stricture, if I may say that. Okay. Balloon up. Yeah. Okay. So
there is some mucoid material that is being swept away, and yes, there is some bit of blood clots too.
Blood clots too. But did you see?
But the sweep was
quite smooth, and the inflated balloon came out. So that means that the stricture is quite pliable. It's not a very tight stricture. That's very important to know beforehand. And you can see on the cholangiogram the duct is pretty clean now. We'll do one more sweep. Inflate.
What is that opacity? The cystic duct?
Yeah, probably
the cystic duct.
Yeah,
looks like that.
Could be a calculus in the cystic duct.
Unlikely to be a calculus, but could be a cystic duct in the contrast which is filled in the cystic.
Contrast which moved into cystic duct.
Yeah.
I'm still not sure why it is, there is so much of blood clot in the bile duct. That probably is because of the EHPVO, but, possibly. Yes. Okay, one more time. Up, inflate. Yeah.
So when there is no stricture, why did he get cholangitis?
No, there is a stricture. I am feeling a rivet of resistance, but it's a soft stricture. It's not a very tight stricture. Okay. Out with the balloon. Let's put in the spy scope now. I think that is the best what we can
go over the wire.
We'll go over the wire. Here, there's no point in trying to be heroic over here.
So you are doing now cholangioscopy?
Yeah, we'll do a cholangioscopy.
So normally how much you dilate the CBD before you put the cholangioscope normally?
Here I would not dilate KK because the papilla, there's a wide sphincterotomy.
Normally?
Normally about 8 to 10 millimeters max. And it also depends on the indication. If I'm doing it for laser, I will dilate much more. But if it's only for assessment, for a stricture assessment, then usually the distal bile duct is much narrower, where you might even have to dilate only up to 6 or 8. So it depends on the distal bile duct, how much you should dilate. Because if the distal bile duct is narrow, don't over dilate also. So 6, 8, 10. So, okay.
Amol, now you have 3 minutes to finish the case because we have pending.
Well, Gaurav told me 10 minutes. I don't know. Whatever time you guys have. Okay.
So we have now 2 orations, facilitation.
Yes, yes,
Okay.
yes.
Dr. Amol.
Yeah.
In this particular patient, we have chronic pancreatitis, which possibly is leading to lower and bile duct stricture.
Right.
Why are we thinking of IgG4 disease in this particular patient?
See, because IgG4 was raised.
How much was it raised?
Gaurav, can you tell me that?
It was 1800 after treatment with infliximab and steroids for ankylosing spondylitis. So this patient has a severe AS for which he has been treated with steroid infliximab in the past, and he's underwent cholecystectomy and a splenectomy for his HPBO and shunt surgeries in the past. So he has a history which is conflicting that it could be IgG4, it could be EHPBO related. At the same time, he also has chronic pancreatitis. So we are not very sure what is this stricture, and we would want to visualize the bile duct, get biopsies, and be sure why is he having a recurrent cholangitis.
So the trick over here is to go proximal. Can we have the fluoro ones? And Shubhata, can you give me the... Okay. We keep irrigating.
Some blood clots over
yeah,
here.
so
Yeah.
we'll try and go proximal and important thing over here is to suction on the duodenoscope, because that will bring the fluid out and your blood clots and everything might come out.
So can you focus on how the suction is carried out on the cholangioscope? Can you move the camera towards the cholangioscope?
Yeah.
Yeah, suction.
Suction.
Just show where you're doing the suction.
Yeah. Now, one way of doing your suctioning is also on the duodenoscope, you keep the suction on, and plus you put a suction on the cholangioscope over here.
Gaurav, now you have 2 minutes more.
Okay, yeah. So, just withdraw it.
Yeah.
Withdraw. Wire.
Wire राहू दे आता. आज wire करायला लागलं तर.
So we are withdrawing from.
We are withdrawing from the hilum.
This looks like a normal duct.
This is normal duct. This is quite normal.
Some blood clots.
The blood clots. थोड़ा खालती दाखव, खालती दाखव. Okay.
Okay. Shaft. So now Dr. Bappa is now moving with the shaft and the big wheel of the scope. Okay.
काढू wire काढू येत मग. We'll pull out the wire because sometimes what happens is with the wire in place,
yes, the movement
of the scope tip becomes a little bit compromised.
Yeah.
So who's handling the spy?
So Shubhada is handling the spy.
Okay.
Fluoro on. Now this is the challenge, Pravir, you were mentioning.
Yes.
So see, I am pushing the scope down as Shubhada is turning the wheels of the spy. And this looks more like an inflammatory stricture to me.
Yes, we still, I think we still are reaching the stricturous area. Yeah.
So
now we are coming to the distal. So Dr. Pravir, your question was well taken. How difficult is spy in lower CBD, pathologies?
So millimeter by millimeter, I am withdrawing the spy scope, and I am using the scope to withdraw it rather than actually pulling on the scope. See, there you can see that. There's a little bit of bulge over here. I don't know what that is.
Inflammatory.
Seems to be
So
some
inflammatory. Looks
irregularity.
inflammatory.
Yeah.
This is more of inflammatory bulge.
So would you take the biopsy?
Yeah, we'll probably take biopsies from here. So what I'll do is now I'll again go more proximal so that I get in a slightly stable position and then put in the forceps and then again pull back in the same manner.
Amazing, Amol, amazing demonstration, how not to fall back and how to image.
So far we've been lucky, VGM. Let us be able to get the spy bite out because my scope is already almost out into the diagram, I think.
Difficult scope position.
Thank you so much. Please give a big round of applause to Amol. So we are just leaving, coming back for the guest lectures.
Thank you so much. Thank you. Thank you.
Thank you, chairpersons. Thank you, all the moderators. Thank you, all the demonstrators. We close the session.
So now we have come to the end of our meeting, and we have two very important orations to go. But before the orations, I have a very pleasant task to perform. And that task is to felicitate a very important person. Because as you know, this meeting is all about ERCP. And looking at the response of this meeting, all of us agree, I'm sure you will agree, that ERCP still is the king of all interventional endoscopy procedures, because that is still close to every endoscopist's heart. So we decided to felicitate the person who did the first ERCP in our country. And for that, my felicitation is going to be for Professor Jung Dilawari, who has had a very illustrious career professionally as well as socially. And after his medical education and colorful life in Germany, he obtained his MRCP from England, where Professor Dilawari had the opportunity to work with renowned gastroenterologists and hepatologists like Sir Francis Avery Jones, George Misewitz, Margot Scheiner, Sheila Sherlock, Roger Williams, and Peter Cotton. It was at that time that Professor Dilawari was invited by Dr. P.N. Chutani to come to India, who was that time the director of PGI Chandigarh, and he was requested to join this prestigious institute where Dr. Dilawari worked for the next 20 years. Dr. Dilawari is credited for performing India's first ERCP and CBD stone extraction. And over his academic tenure, he has many awards, prestigious positions, referee for reputed journals, and published more than 200 papers. Today, when we are just finished this first of its kind focused ERCP meeting, we want to felicitate the person who started ERCP in our country. And there's no other better person to felicitate him than his own student, who is equally illustrious, Dr. Nageshwar Reddy. Dr. Nageshwar Reddy, please felicitate Professor Dilawari.
Thank you. Now we have the time for orations. And
1 minute.
Oh, sorry.
Amit, thank you very much for giving me this honor. Where did you get all these photographs? You've been spying on my private life. Well, my short story about ERCP is, I started ERCP first about 48 years ago in London with Peter Cotton. And that time, Peter Cotton had just come from Japan after learning this technique for 6 months. And we started this in Middlesex Hospital, London. And Peter was very dynamic, very quick. And I used to also say, Peter, let me also do the ERCP. He said, no, not yet. So then he allowed me to do side viewing endoscope, reach the papilla, and then he will take over from me. I said, Peter, let me cannulate at least once. Whenever I do that, but let me cannulate once. So then he let me allow to do some cannulation, and that's how I learned my ERCP. Luckily, I was then invited by Dr. Chitani in PGI, and when I reached PGI, I did the ERCP, removed the bile duct stones, traveled in India to various medical colleges. But then in my unit at that time, this bright young man, Nagesh Reddy, was working with me at that time, and we did ERCP together. I was very lucky to have him. As you know, he's so famous, so my popularity goes with him as well up. Peter Cotton used to say that he's the grandfather because Nagesh Reddy became my son, and I was Peter's son in a way. But now I have become grandfather as well. I'm sure you have taught many students as well. And then I was invited by Dim Suhendra to visit his unit. And when I went there, he talked to me day and night about this man. He talked about him all the time. Amit, Suhendra talked all the time about you and Nalima. And I said, well, I must go and see him in Bombay. I went to see him in Bombay, and he used to do a lot of this, his own catheter, his own stents and everything. And when I went to PGI after Germany, I invited him. I invited him as a visiting professor to PGI. And it was not a popular event because a government hospital, a professor in government hospital inviting a private person settled in Bombay. But I didn't bother me at all. So he came and helped our unit tremendously, making stents and catheters, and I'm very grateful to you for coming over there. So I'm really very happy that you invited me to this, to facilitate, and thank you very much indeed. So two people I really owe my thanks, Nagesh Reddy and Amit Mahadev. Thank you.
My job would be incomplete if I don't invite Dr. T.S. Chandrasekhar to say a few words about Dr. Dilawari, because he is another student from PGI, and he has very interesting stories to tell.
When Amit announced it, ERCP live for 2 days, 3 days, we were all very skeptical. How he's going to get the crowd and how many cases is going to get. I think he did a wonderful job, and it's going to be the trend now. I was a resident in PG Chandigarh, very hot summer, unbelievable scorching hot. The early 80s, I remember May 1981, Nagi had not joined. Some of you in the audience may not have been born. And I was a young resident, and I was posted under Dr. J.B. Dilawari. I was a medicine resident. So he called me, Chandra, that we are going to have 1:30, we are going to do ERCP. Can you tell me the explanation, expansion of ERCP? So I told him, then he said, you are the right person to assist me and all. So we went to the fluoroscopy room. There was no AC. The patient was a little fat woman. And I was ready with all the armamentarium. What armamentarium? We had one diagnostic side-wing endoscope, one green wire, and one cannula, and one sphincterotome. And full of enthusiasm, Dr. Dilawari. I just want to tell you how the first ERCP was done. and Dr. Lamba was there to help us to do the fluoroscopy. I was a poor resident. I was feeling very hungry. I didn't have breakfast that day. He said, nothing can be done. Now we have to be there by 1:30. So we wheeled the patient there and he started doing it. After 20 minutes, he started sweating because the AC wasn't working, but full of enthusiasm. Patient also started a little bit of sweating and the anesthetist also wasn't there. So we gave Fortwin and Phenergon. So everything was all right. Then quick peristalsis came in. So he may not agree with me that I gave the buscapine that time. You tell me then who is responsible for the success of the story is.
Wow.
Now it is very obvious.
That is phenomenal.
So you don't have to, to tell that. So quietly I gave buscapine, everything opened up now. No peristalsis, nothing. Suddenly he looked at, I don't know what is the magic was done. And then he cannulated and extracted the stone. And the PGA director was also waiting that the great event to happen. I am adding little bit mirch masala and all just to make it interesting. And the whole unit was really elated. And he was very kind enough to take me to the upper cafeteria. He gave me a cup of tea and bread pakoda. I survived because of that one little today then. Otherwise I would have become really bad. And he was more kind enough because then I told the story that I gave buscapine, he was very successful. Then he was very kind enough to give one more bread pakoda to me. So I was done with that day. And next day when I opened the Tribune, the local newspaper, it came in, PJ Doctor. That's the first stone removal from the common bile duct. That is a history. This is the time you have to clap now. Because you are so engrossed in the story, you may not know that when to clap. So this is the thing I keep telling my thing. So Dr. Dilavari, greatness about Dr. Dilavari is, and whomever he talks, he brings down his age. If he talks to me, he'll become 34. If he talks to Priyanka, he'll become 24. If he talks to Barham, he will become maybe 32. Something. That is a greatness. And he never showed his superiority or I'm the professor, another thing. And other second important quality of him is ready to learn at any point of time. He will be in the first row to attend the conferences. And he first time met me, he said, Jesus, what is the malarial, parasite, everything he would like to know that. He is a very explorer. He's a great explorer. And we are very fortunate to have students, we had two teachers like him. And he created, you name, I will tell you the names whom he has created. Dr. Patrick Kamath, Dr. Santi Swarup, Dr. Nageshwar Reddy, and Dr. Chari. They're all in Mayo Clinic now. So that shows the greatness of how great a teacher here. The first year, now you got a point, when to clap. Very good. I'm very happy that. So this is the first ERCP incident not to be forgotten. So thank you, Chief, for the great thing you have done. And I'm very glad that the right appropriate situation, Dr. Amit Medyu has recognized you, the man who did the first ERCP. And after several years, 3 days conference can be held means that should the time, ERCP stood the time of time. Thank you very much for this wonderful opportunity.
Thank you, TSC. Now it is the time for the oration. May I have the honor of calling Dr. Jang Dilavari sir, Dr. T.S. Chandrasekhar, Dr. Akash Shukla, and Dr. Amit Mahdev as the chairperson. Please start the proceeding, sir.
Yeah. May I invite Dr. Professor D. Nageshwar Reddy to deliver his talk, Oration on Endotherapy of Chronic Pancreatitis. Where are we headed? the right person for the right talk.
So friends, it's, shall I start? Yeah, it's a great privilege to be giving this oration, and I'd like to thank Amit for giving me this opportunity, especially the opportunity to felicitate Jung Bahadur Dilavri. Jung was, of course, my professor, my teacher, and people ask me, how good was Jung? In fact, just in the hospital, somebody said, how good was Jung in endoscopy? I say it's not how good was he, how inspirational was he. He inspired a generation of endoscopists, not only me, but many, many others who took up endoscopy as a career. I think it was his style of doing endoscopy, his way of how, like what TSC said, that boyish enthusiasm used to have for that, which actually stimulated many more to take up this. And Jung, thank you for everything you've done for endoscopy in India. So we don't want to call you the grandfather because you're still not aging. So we still maintain that you are the one who started all this, father of endoscopy of the country. When Amit was telling me about this lecture, about the ERCP workshop for 2 days or 3 days, I was a bit surprised. I thought, do we have so much in ERCP after 40 years to have a 3-day course? And now after these 3 days are finished, I realized what a fantastic job is done. To get the variety of cases, now you can clap as TSC is there. The fantastic cases that been actually broadcasted over the last 3 days. I think the variety of procedures, technicalities that occurred, and I think the flawless transmission are all, of course, testimonial to his organizational skills. But I think it requires a lot of courage to even think about a workshop like this. You know, in 2023, to think of a single theme ERCP workshop, calling the best in the world internationally to come and participate in this. It takes a lot of courage. And Amit, I think this is, again, a testimony to your leadership and the quality of course, endoscopy that you have brought into this country. Thank you very much. Yeah. So my talk is on endotherapy of chronic pancreatitis, and I'll start first with these pictures. We started this journey very long back. In fact, in 1990 or 1989, I first visited NIPS Ohendra to see what was happening in the field of endoscopy. At that time, Amit was also a very preeminent member of that team, and of course, I had the hospitality of Amit and Nib, stayed for a few weeks to see what is happening. Over the period of time, endoscopic therapy for chronic pancreatitis developed. There are many things that remained changed, many things that remain unchanged. And one of the things unchanged, of course, is Amit, you see, not changed much since then. I have changed, especially my hairstyle. And this was a picture just yesterday. We took both of us together, a very nostalgic picture. And you can see again that endoscopic therapy of chronic pancreatitis, like I'll show you, has both changed and unchanged. In fact, I got this paper out. This was almost 15 years back when we wrote this paper together. In fact, the paper was mostly written by Amit, and I was one of the co-authors. Endotherapy of chronic pancreatitis with intraclavicular stone. In fact, if you have an opportunity, I request you to get this paper out, because if you go through this paper, what is remarkable is that endoscopic therapy of chronic pancreatitis, the philosophy has not changed over the last 40 years. It's exactly the same philosophy. What has changed is the techniques, the technology, and of course, we have better ESWL machines, pancreaticoscopy and so on. But the whole principle of pancreatic decompression endoscopic therapy has remained same. So what I'll do over the next 15-20 minutes is to go through this journey of what we can do in our patients. The most important thing to remember is that for endotherapy of pancreatic disease, the main indication is pain. Main indication in chronic pancreatitis is pain. We do not do this for steatoria, for diabetes and so on. And pain in chronic pancreatitis is a very complex phenomenon, as you can see here. We used to think that ductal hypertension was cause of pain. It's a cause of pain in about 2/3 of the patients, and that's why whatever you do in these patients, only 2/3 will get relief of their pain. The other factors like local oxidative stress, but what we're now increasingly realizing is that it's a neuroplasty, the neurons that are there on the pancreas which get hypertrophied, which are causing the pain. And of course, this results in central neuroplasty. So what happens ultimately, if the patient has pain 10 years, 15, 20 years, there is a central neuroplasty. So whatever you do, even if you remove the pancreas, his brain keeps saying that there is pain in the pancreatic area. So this central neuroplasty and its understanding are becoming more and more important. The new pharmacotherapy is coming for that. That's for a later period. But right now, I want to emphasize again that the indication for endoscopic therapy is pain, and pain in 2/3 of the patients is because of ductal hypertension, and this has been shown by some early canine experiments. And if you relieve this obstruction, probably they get relief of pain for some period of time. And the cause of obstructions is stones and strictures. And again, over the last 2 days, you have seen many, many cases of the stones being removed and strictures being ablated with stenting. So pancreatic stones are a little different, and this is something you didn't see in this workshop because it is not done. Most of these stones cannot be removed by single sphincterotomy and removal because they are very difficult. Only small stones less than 5 millimeters in size can be removed by this. And on the right-hand side, you're seeing an ERCP I did in a patient who had an impacted pancreatic stone. In fact, there was a rare case where I could catch the stone with the snare. I put my leg on the ERCP table and started pulling on this to ultimately get this stone out. A large 5 centimeter stone, which was at the ampullary edge, which could be finally taken out with relief of pain. So this type of situation is not common in pancreatic endotherapy, and what happens in most of these patients is this. This is a slide I borrowed from my surgeon friend, Dr. G.V. Rao. You can see what happens is most of these stones are stuck to the mucosa there in the ductules, and you saw a very nice demonstration from Rangsan this morning, how the stone was stuck into the ductule on the side. These stones cannot be got out by standard endoscopic therapy, and that's why what we do for the bile ducts is not true for the pancreatic duct. So what we have to do in these cases, of course, is an extracorporeal shock wave, pulverize these stones completely, make them into small bits, and then you can clear the pancreatic duct. And again, you have seen several examples because again, Amit probably has one of the world's largest experience in this area, how these stones are so pulverized, you can't even see them when you try and remove them. So based on the experience that we've had, and this is the guideline from ESG for which me and Sandeep are part, the recommendation of very high level for removing stones more than 5 millimeters in the pancreatic duct with a combination of extracorporeal shock lithotripsy and removal of these stones. There are several factors which influence success rate, the patient factors like stone density. You can see one of the stones that they showed here did not fragment even because it was so hard. The duration of the disease and narcotics are very important. In our country, we are fortunate that most of these patients are not started on narcotics, so they respond. Technical factors, again, are very important. You have seen excellent fragmentation here, and the reason is that there are 3 things which are important for fragmentation. First is the machine. There are many, many ESWL machines, and in your practice, kindly don't send this patient to the urologist. If you send to the urologist for ESWL, they will fail. They got inferior machines, they don't have the patience to do it, and so on. There are very specific, only 2 or 3 machines, I can't, of course, for commercial reasons mention the names, which are useful for fragmenting the stones. Second is the operator. You see here, Dr. Vinod, for last 20 years, the only thing he's been doing in his life is baking pancreatic stones. So he's become very experienced, so that's very important also, operator. The third thing that influences your success rate is epidural anesthesia. All our patients get epidural anesthesia, and when you do this, you can actually control the patient's respiration, and your fragmentation success is very high. Because the ultimate aim is to pulverize these stones into such small powder, and again, you have seen this in the live workshop. These 2 days, many of these cases are just pulverized so that only small fragments come, and so that you can completely clear the pancreatic duct. There's another concept that's coming up, and again, I think Amit mentioned this yesterday, that a team in Europe, especially the Brussels team, feel that you don't have to do ERCP at all. If you have a good ESWL machine, if you have an appropriate anatomy like this, the stone like this, you can crush these stones completely. They become very small fragments, come out of the papilla, and ultimately you can see a dilated duct like this completely shrink. So if you have the appropriate anatomy, you have very good ESWL machine, even ERCP is not necessary, these stones can be fragmented. So this is the large experience that we reported recently from our unit of over 5,000 cases where we could achieve complete clearance in 72%, but even if you do partial clearance, you still have benefit in these cases. Only about 10% of the cases, like the one again you saw today, where we couldn't completely pulverize, which required a spicolangoscopy, that required this. And this is a systematic review and meta-analysis of several studies that have been published since then, showing a very high success rates of completely being pain-free and stone fragment-free. You can see here that although 86% of the cases, the stones have been completely taken out, only 2/3 of the patients get relief of pain, and this is because of the neuropathic component that is there. Now, what are the factors that decide whether response to this endoscopic therapy is there or not? And this is a very nice study from David Whitcomb's unit. We showed, if you actually summarize this, what it showed is that endotherapy is effective for stones which are in the head. The disease duration is less than 5 years. The pain is not continuous but intermittent. There is no narcotic use, and they are non-smokers or have stopped smoking. In this group of patients, endoscopic therapy is extremely useful. The reason why this is important is this is a costly therapy, extracorporeal shockwave, endoscopic therapy. We have to warn our patients before itself that you are going to respond or not. So we select our patients carefully. Head lesion, not smoking, short duration, you are very, very sure that this patient will respond, no point in going for therapy. But the most important thing in endoscopic therapy of chronic pancreatitis is a chronic disease. You have to look at chronic results. Most of surgical results are about 10 years, 15, 20 years reports that are coming in. The first study which looked at the long term was, again, Jack Davies unit, which looked at 11 years to show that patients who had endoscopic therapy with ESWL, even after 11 years, were pain-free. And subsequently, this was the largest study that we published, again, chronic pancreatitis endotherapy. And you see that both intermediate 5 years follow-up and after almost 10 years follow-up, many of these patients remain pain-free, and they do very well without other interventions. So long-term, we now have data for up to 10 years saying that this therapy is effective actually to counter some of the surgical argument. The problem with extracorporeal shockwave lithotripsy to a large extent in the Western world is that ESWL is not easily available. You're depending on the urologist as some parts of the country, so this is a problem. And if you have a study actually which looked at comparison of urologist versus gastroenterologist directed ESWL, and you find that gastroenterologist directed is much more successful. That's why don't send your cases to urologists. They'll won't do it, and of course invest as reimbursement issue. So that's how pancreaticoscopy came in, and in a suitable case like this dilated duct, again you have seen this very nicely, you can use pancreaticoscopy to completely pulverize these stones. And this again you can do with the spicolangoscope, convert it into a pancreaticoscope, and again we see this very nicely in this workshop. So the advantage of pancreaticoscopy, of course, is availability for most endoscopies. In one session you can finish. You're not dependent on a urologist or some other person to break the stones. But in my opinion, this is definitely an inferior method to extracorporeal shockwave lithotripsy. In your units, you should not start pancreatic endotherapy unless you have a good access to extracorporeal shockwave lithotripsy. Otherwise, depending on pancreaticoscopy is not right. It's only some few cases which have dilated ducts which you can show. Otherwise, you can see that literature suggests, especially from Raj Shah unit and others, and Amit also has published some of this, that you can do a good job, but in a very, very small segment of patients. There have been some studies comparing extracorporeal with pancreaticoscopy showing that similar rates, but I would suggest that in most cases, in an average endoscopy unit, it should be extracorporeal with endoscopic therapy. In patients who have radiolucent stones, it's a good idea to balloon dilate like this, completely open up the papilla, and then these very soft stones can be taken out. Even if they are large in number, you can see the large chunks of stones will come out like this very easily. So this can be done. So if you see a radiolucent stone, kindly don't have to go for ESWL. For pancreatic strictures, of course, is another component. We had a nice talk this morning. But what we're now doing is not put single but multiple plastic stents over a period of time to dilate the strictures and kindly clear them. It's important that you treat strictures only in the proximal part of the pancreatic duct. You put multiple stents, not single stent, and stenting has to be done for 1 year. This is another very important thing. People do short-term stenting, they're going to respond. You have to put these stents for 1 year. Of course, we also talked about biliary SEMS, the bumpy stent which I've used in some cases. Again, data is not very strong. But what about other forms of therapies? The problem is all these therapies are for dilated pancreatic duct, and if there's stones, patient gets relief. If you have a patient who has non-dilated duct, no stones, what do you do? Of course, celiac ganglion is one of the things that we offered. I won't go into the other techniques for complications of chronic pancreatitis because that's another chapter. But celiac ganglion blocks, I would discourage them, only temporary period. We have shown that US guided is better than percutaneous, but they act only for very, if you're desperate, elderly patients, you can do it, but it's not something that we would recommend. Biliary strictures are very common with chronic pancreatitis. As you've seen here, 20% of the cases, and we showed long back that metal stents, covered metal stents are useful, and this is a randomized study that we published in Gastro a year back, where we showed that compared to multiple plastic stents, completely covered metal stent is equivalent with less number of ERCPs and cost which is probably a little lower because you're doing only one procedure. This very clearly showed that a certain group of patients, especially with a stricture size of less than 3 centimeters, absence of head mass, absence of dense calcifications, are the ones who will respond to endoscopic therapy with a completely covered stent. So now there's always this fight between surgeons and gastroenterologists. Who should go for endoscopic therapy? This came up because of a paper which came in New England Journal, which seemed to support surgery. So we actually, me and John Minster, who is a pancreatic surgeon, came together to write up this editorial to decide which patients. And it's very clear, if you have a stone which is in the head region, small stone, then of course endoscopic therapy is good. If you have multiple stones, dilated duct, if you have an experienced unit like in Amit's, you can do endoscopic therapy. But if you have a situation like this, large number of stones, multiple strictures, or a head mass, then these patients directly go for surgery. So management of chronic pancreatitis has two types of approaches. There are people who do a step-up approach. I'll talk to you about that. And there's those who do an individualized approach. The step-up approach is promoted by certain, again, gastroenterologists who feel that patients with chronic pancreatitis should go with medical therapy, stop smoking, neuromodulators, no response, endoscopic therapy, no response, surgery. This is the problem here with this step-up approach. The problem is that by the time the patient goes to the surgery, he's already done so many things, he's exhausted his money and he's exhausted his pancreas also. These patients don't respond and the surgeons are not very happy. You're sending them a pancreas which is completely battered with several endoscopic therapies and so on. So I think this is something which to a pure pancreatologist does not seem to be the right approach. The reason again why this came up is because of this papers about chronic medical versus, endoscopic versus surgical therapies. Initially New England Journal, followed a long-term follow-up in gastroenterology suggesting this better. And conclusions from these studies were that surgery is superior. But again, I don't want to go into discussions of limitations of these studies. There's several, including a low number of patients. There were technical difficulties and so on. I'll just point out this, just to point this out, why there are limitations in this is this. Look at this study which came in JAMA in 2020, which says that in ESCAPE trial, it's called, it's an RCT of surgery versus endoscopic therapy. You can see very clearly that surgery did much better than endoscopic therapy. Okay, conclusion was surgery is better. But if you actually go into the study more carefully, if you actually dissect the study, we found very clearly that in endoscopic therapy, there are two groups of patients. Those who had complete clearance of the duct, who do as well as surgery, and those who do not have complete clearance, who do not do well. If you mix both these groups, you get this graph, but if you separate out, you get this graph showing that efficient endoscopic therapy is as good as surgery. And this is a very important point to consider when you're looking at patients. Of course, there's several problems when you're trying to look at studies in future. You want to compare surgery with endoscopic therapy, the quality and limitations of the studies, the heterogeneity of the population. Most important is this is operator dependent. If you get your endoscopic therapy done in a unit which is very used to this, like for example Amit's unit, your success rate would be 70 to 80%, provided the right patient is selected. But if you go to a unit which is not experienced, then your success rate is only 20%. So this is very important, and therefore these studies have a lot of limitations. What do we do in future? In future, we need to adequately assess the pain, have tools for that. We're getting it now. We have to have sham control studies. We have to take out the confounders like alcohol and smoking, and of course timing on intervention and long-term follow-ups, all very important to decide the forms of therapy, and we require more studies. So finally, in conclusion, to try and tell you what we would do in chronic pancreatitis, I just summarize this again, the philosophy of what was in the paper 15 years back. If you have patients with chronic pancreatitis with dilated duct and a single stone or stones like this in the head region, we do extracorporeal shock lithotripsy, follow it up with or without endoscopic therapy to have benefit. In those who have multiple stones or strictures, we do endoscopic therapy to clear the stone, extracorporeal with stenting. And in those patients who have multiple stones, multiple strictures or a head mass, we would send these patients directly to surgery and not do endoscopic therapy. The non-dilated ducts are the problem cases. There are a lot of things like medical therapies, celiac ganglion blocks which are coming, but these are the most difficult. There is a tendency in some units nowadays, and we have some experience also in these patients with non-dilated ducts, very severe pain, to do a total pancreatectomy and islet cell infusions into these patients to prevent brittle diabetes. So this is one of the options we have, and of course complications are treated separately. So chronic pancreatitis is a teamwork. Physicians, endoscopists, surgeons, interventional radiologists, all coming together. And in majority of our patients, we select our patients properly. I think we can give adequate relief with endoscopic therapy like you've seen in many of these cases that have been demonstrated in this workshop. Again, I'd like to take this opportunity to thank Amit for giving me this opportunity to give this talk. Thank you very much, Amit.
So thank you, Nagi, for the fantastic oration. As usual for orations, we don't have question answers, but you are the master in not only in endoscopy, but you have done tremendous amount of work in chronic pancreatitis. Both of us started together around 30 years back. And we know that it is endoscopic therapy is definitely going to stay. But the message has to be very clear, how to choose your patients properly. Yes. And that is what you have done exactly today. Thank you so much, Nagi.
Thank you.
Thank you.
Thank you.
I would now like to introduce our second speaker for the second oration. I intentionally did not introduce Nagi because trying to introduce Nagi for this audience is like belittling his stature. Because all of you know who Nagi is, and I don't think he requires introduction. But Barham I need to introduce because he comes from Mayo Clinic. And Barham is a professor of medicine and vice research chair for innovation at the Department of Medicine, Mayo Clinic, Rochester, Minnesota. He's director of advanced endoscopy at the Division of Gastroenterology and Hepatology. He did his postgraduate medical training at Harvard. More importantly, Barham is an inventor of multiple medical devices and surgical endoscopic procedures. He has more than 280, I think around 300 peer-reviewed publications in top journals, including Lancet, received multiple awards, including the Jordanian Star of Science Award, given by His Majesty King Abdullah, and of course, the Surgical Innovator Award given by the ASGE and American Society for Bariatric and Metabolic Surgery. So Barham, today I'm going to give you a very special topic, and that is what is going to happen ahead for ERCP.
Well, thank you for the kind invitation and the honor to give the oration, Amit. Thank you, colleague, for inviting me to this beautiful country of India. I love India and I consider it second home, so it's with pleasure that I deliver this lecture. So this is a little bit of a futuristic talk because I truly believe in the power of innovation to meet the needs of our patient and to keep pushing what we're capable of doing therapeutically. We stand on the shoulders of giants that most of them are sitting here, who paved the way for the future of what ERCP is going to be looking like. And with that, for that, we appreciate all they've done, and they deserve a round of clap. So these are my disclosures. I do work closely with the industry, and that's one of the messages today. No advance in innovation is going to be possible without having a healthy and transparent collaboration with the industry. So it's not bad to collaborate with industry. Actually, it's good for the health of our field to collaborate closely in a transparent fashion with our colleagues in industry. Also, I would like to remember one of my colleagues who've passed away recently, Dr. Michael Levy. He himself was an innovator and a significant contributor to the field of ERCP and endoscopic ultrasound. So why do we innovate? We innovate because we need to meet the needs of our patient, because we truly desire to have better solution for a better future of our discipline. And in this particular case, we're talking about ERCP. Sir Albert Einstein said, learn from yesterday, live for today, and hope for tomorrow. But the critical part, the important thing, is not to stop questioning and not to get comfortable with what we have as far as therapeutics. So we're embarking on a very brave new world, and I would like to highlight it for all of you. And this, I broke down what I see the future lies into 3 different domains. One is digital, and there we're going to talk about artificial intelligence, augmented reality and virtual reality, and enhanced imaging. This is crucial to our field. Second is access, and we're going to talk about robotics and EOS-guided access, which would likely become a norm in our field. And then finally, we're going to venture into novel therapeutics to include novel energy modality, immune and gene therapy, and all will be very highly relevant to the field of ERCP. So let's start with digital and start with artificial intelligence. And this is one use case of the value of artificial intelligence. We've seen many cases of cholangioscopy and pancreatoscopy during this course. And now we're in the era where we could have a computer help us do what we do. This is an indeterminate stricture in the bile duct. And this is an algorithm that we developed at the Mayo Clinic that gives you the probability, is this cancer or not cancer? And if it's cancer, where is the best area to sample with the probability of getting a diagnostic sample? So this is we could look forward in real time to having a tool to aid us with cholangioscopy. And this is courtesy of my colleague, Dr. Vinay Chandrasekhara, who is with me at Mayo Clinic. And we published our early feasibility work in GIE showing the value of this algorithm in determining the malignant probability of an indeterminate biliary stricture. Let's go to AR and VR now, augmented reality and virtual reality. And I'm sorry to say it's sad that we're still looking at images like this. 2D images of overlapping segments that do not fully appreciate what's going on in the intrahepatic bile duct. We have sophisticated MRIs that we could spin them, turn them, MRCPs. I do a lot of PSC at Mayo Clinic, and this cholangioscopy is simply insufficient to address my needs doing PSC type of work at the Mayo Clinic because of the overlapping duct. So we could do better, and we have the technology to do better. This is a video highlighting the power of virtual reality and augmented reality. This is borrowed from surgery, but you could see the implication of using augmented reality to take an MRCP and superimpose it on the cholangioscopy or on the cholangiogram in order to have 3D rendition of what we're trying to do and what we're trying to access. So I'll have the video narrate itself. We're not having volume here, so I will narrate it. Basically, what we're seeing here is the idea of taking cross-sectional imaging, where they're coming from X-rays, CT scan, and MRIs, creating a 3D rendition of these images, and now superimpose it on the surgical field that you're trying to impact. And with that, for example, now you could take the MRCP, create a 3D rendition, use a goggle that takes that 3D rendition and superimpose it on your field. So in real time, you could be now looking at a 3D system that you could spin with your fingers and say, I'm not accessing the right posterior duct, and I need to go here, and this becomes highly relevant in states where you have intrahepatic disease like PSC or living donor liver transplant, which we miss sometimes the right posterior duct because we do not know where to access. Then let's go about talking about enhanced imaging, and enhanced imaging is also an important area because light is our friend here, and I'll have the video narrate itself as well. the 3D renditions of the image in front of you, you could see this vasculature changes. So accepting the images that we have in endoscopy is not sufficient. Therefore, I think looking at 3D imaging and enhanced imaging is going to be also part of our future. So now let's go to robotics. And this becomes highly relevant because we saw the masters in this course struggling with mechanical advantages. We still have a very mechanical systems that we are not stable, so we do not have manual dexterity to do the work that we need to do. How many had the spyglass fallen out of that patient? How many times we struggle to get the spyglass in a stable position to do lithotripsy on a stone? And that's simply because our equipment that we have, although they do the job, they're not sufficient to take us to the next level. And the fundamental reason for that is we work, so here's the lens of the scope right there, and here's our eyes, and here's our hands. We work where our hands and our eyes in the same plane of motion. That's where robotics could transform what we're doing, because simply stated, we now need to separate our field of work from our field of view in order to get this manual dexterity. So we're embarking on the era where we're going to have single-channel robotic systems. This comes from Intuitive, but you could see now we're separating our visual field from the area that we're working. Now, how does that apply to ERCP? And that applies basically from the single-channel robotic platform that now they're clinically available in the bronchial tree. You could see how what works in the bronchial tree is going to easily work in the biliary tree. This is a system from Johnson & Johnson. It's the Monarch system. It's image registry and image guidance. So you take the CT scan and you tell the CT scan that there's a peripheral nodule in the pulmonary tree. Think about this similar as to the ball tree, and now you're having a joystick with a robotic single channel that takes you to where you need to go. And it's image guidance, and you could see the stability and the dexterity. You are not struggling to push this. There is one-to-one motion, there's rotation on axis, all maneuvers that we do not have in ERCP today. And you could see having the value of something like that. How many cases in this Congress could have utilized this technology in order to do what we've done in a very easy fashion that does not require the expertise of very seasoned and experienced operators. Now you get there, and once you get there, you're capable of delivering the therapy. Let's say this is a stone rather than a tumor, and you got there now with image guidance, with complete stability because of the robotic platform, and now you are ready to deliver energy or to deliver therapy for treatment of that structure. Now, it does not need to have a whole platform. You could see now we will gonna get robotically enabled accessory. So think about this technology as a catheter that you could deliver through ERCP. It's a robotic catheter, and you could see that you could spin and you get one-to-one motion. You have manual dexterity, you have interventional dexterity, and this technology is being applied in the cardiovascular space, and we look forward to having this technology come to ERCP because it's going to be hugely valuable, and we do not need to struggle anymore with having a mechanical advantage in doing what we are doing. Now, EUS guided access is already kind of becoming a norm, but it will continue to push the limits there. And in EUS guided access, as far as ERCP, we have EUS guided choledocho duodenostomy. And with that, we're accessing the bile duct from the duodenum to deliver a stent that will palliate a distal obstruction. And in the near future, multiple colleagues in industry are working on a very efficient biliary access systems to allow us to do this procedure with simplicity and high safety margin. The other access point is a hepatogastrostomy, and similarly, the same tools that they're developing to access the extrahepatic bile duct could be used to access the intrahepatic bile duct. And this is an example of accessing the left lobe of the liver with endoscopic ultrasound in order to place a stent, and the stent becomes your conduit or your next papillary orifice, so to speak, in order to do therapy above the hilum. And this becomes very useful when you have cholangiocarcinoma or you have severe structuring with PSC, and now you need to do work from the left side of the liver and deliver effective therapeutics. Again, you get access, and once you get access, you deploy a fully covered stent, and that stent becomes your new access point to the biliary system, and you could deliver your therapies very effectively. This procedure truly have revolutionized what we could do above the hilum, and I think it's going to continue to evolve and become a standard of practice. And of course, the third access point is EUS-guided cholecystoenterostomy, which is accessing the gallbladder. And again, here is a gallbladder on endoscopic ultrasound. Now, within seconds, you're inside the gallbladder and deploying a stent in order to palliate cholecystitis or to remove stones from the gallbladder and deliver therapies as well. And that's now is enabled because of the technology of lumen-opposing metal stents as shown here. Now let's conclude with novel therapeutics. All right, we visualize what we need to visualize using digital technology. We get there in a very stable orientation. Now we need to deliver therapy. And here we're going to have a lot of development and innovation that is walking away from heat-mediated therapies into non-thermal energies that we're going to highlight for you. So what's the limitation of heat-based energy modalities? Now we realize that the immune system is a strong player in palliating cancer. That means if you get the local immune environment in the tumor to activate, these T cells are very potent against cancer. The problem is when we try to use heat-mediated therapies, we're not only killing the tumor cells, but we're also killing the lymphatics and destroying the vasculature that will get the immune system to that area. That's why radiofrequency has not played a major role in palliating cancer, at least endoscopically, because we're getting protein denaturation and coagulative necrosis. We have decreased availability of intact tumor antigens. We have inability to mount adequate and sustained immune response because we destroy the structures and the vasculature around the tumor as well. And there's also collateral damage to key structures where we're trying to treat. So here, for example, this is microwave and this is radiofrequency, and you could see you're having coagulative necrosis, you're developing scar, and the scar is destroying the lymphatics and the vasculature, and you're not having a uniform ablation of the field that you're trying to treat or ablate. Now, this is the existing paradigm, is heat dissipation and forming a central scar without effective treatment on the periphery. And that's what's the power of non-thermal ablation with pulse electrical field is it will overcome these limitations. And the non-thermal energies that I'm going to talk about is pulse electrical field, or what's referred to as electroporation. We're going to talk about sonoporation, low energy laser, and then forming ice or using ice as an ablative modality. Now, what's pulse electrical field? Simply stated, physics 101, you put a cathode and anode around the tumor, you develop a high voltage electrical field for nanoseconds, and now the cells go into a programmed cell death rather than coagulative necrosis. Here is an example of technology that using electroporation for endoscopic ultrasound. Again, 2-needle system. You have a cathode and anode in a flexible needle platform. You're putting the electrical field for a nanosecond. The phosphobiolipid membranes of the cell lyse. Then the cells will go into programmed cell death and apoptosis rather than coagulative necrosis. And now there's no limit. There's no heat sumps. There's no, the treatment is uniform because unlike radiofrequency, which I showed you the limitation, now the entire field that's being treated is being treated equally, and you're preserving the vasculature and the lymphatics. to activate the immune system during that therapy. So here is, remember the liver I showed you with microwave and with RF? Now this is with electroporation. You could see a spherical, uniform, ablative effect without coagulative necrosis. This is stained for markers for apoptosis. And you could see this is the overlapping field that you just ablated in that liver. And green means no heat, and you've done this without thermal injury or without affecting the vasculature around that tumor. Now, not only you could ablate spherical solid tumors, but now this technology is available to ablate into hollow structures like we have in the biliary tree or the GI tract. And this is coming from a company called Endogenics, where it's a flex circuit microcircuit system that allow you to take a hollow structure, straighten it up, and deliver this electroporation through a large surface area that's agnostic to depth. That means now we could treat all the way to the muscle without the risk of injury or damage to the structure because of the aerothermal nature of this technology. And you could see here, this is the structure treated. And now you're, instead of seeing coagulative necrosis, you're seeing ghosting of these cells, and these cells go into programmed cell death. So it's a very peaceful environment that is allowing you to ablate that tumor with high safety margin. Now, what about ice? This is a very intriguing concept. Now we're going to have these catheter that could deliver an ice ball. You could put them through a cholangioscope, or you could put them into an EUS needle, and what they give you is immediately an ice ball. So think about this in the biliary tree now. You're putting this in your cholangioscope and forming an ice ball to deliver cryotherapy at high safety margin because there's no gas being emitted by this. Or think about it that you're putting this into a pancreatic tumor with EUS needle and doing the same. So very intriguing and interesting concept. We'll finally conclude with immune and gene therapy. And here's the concept that the tumors like cholangiocarcinoma or pancreatic ductal adenocarcinoma shield themselves from the immune system. They develop a very aggressive anti-immune environment within the tumor. They develop this scar tissue around them to protect them from the immune system. So the question is, how do we reset the immune system and let the immune system now target these tumors? And that's the basis of combining electroporation to reset the immune system with delivery of a cargo. And the cargo could be CAR-T. CAR-T is activated T cells that target this tumor, or it could be monoclonal antibodies, and this is nanotechnology that you could deliver these spheres that gives you antibody against CD40, which silence the anti-immune environment of that tumor. So now these T cells could come into that tumor and effectively treat that tumor. And finally, ERCP is going to be a conduit for delivering gene therapy. This is from my colleague Vivek Kumbhari, a nice review in Gastro that shows that now you could inject these vectors of plasmid with genes with an ERCP approach in order to treat multiple human diseases using ERCP as a platform for delivering therapy. So in conclusion, we should embrace change and challenge dogmas. We're looking for incremental evolution in approach beyond the current focus on ERCP as a commodity. We're not looking at the next bigger jaw forceps. We're not looking at a better pushability wire. We're looking at paradigm shifters to ensure the continued success of ERCP. As the CEO and the co-founder of Netflix said it very nicely, and I quote him, "If you are unwilling to disrupt your business, there will always be someone willing to do it for you." So we should be the people disrupting our business in order to ensure its longevity. It's not easy innovating. Sometimes you're labeled as the villain. It's not always glorious to be challenging the status quo, but as Gandhi put it, first they ignore you, then they laugh at you, then they fight you, and then you know that you won. And I think that's the status of innovation. And with that, thank you for your kind attention.
Professor Daya, that was an amazing, outstanding talk. You really took us to the next level. I think we feel that we have seen something 50 years ahead of what lies us. So thanks a lot once again. for gracing this occasion. Over to Amit for his comments.
So we have now come to the end of our ERCP Live 2023, and I'm feeling very sad that last 3 days have been mesmerizing, and because I had not expected that it's going to turn out to be like this. But I'm sure most of the meetings in the future are slowly going to become a theme-based meeting, single theme meeting, because they carry much more meaning, more significance, much more academic content, and probably much more useful to the attendees. So I hope we have a similar meeting again in 2024. And with this note, I would like to conclude this conference and invite you all to have lunch. Today being a Sunday, we have another surprise for you, that we are going to serve some beer along with the lunch.
Wow.
So let's disperse and meet for lunch.
May I request everyone to give a standing ovation, except for those guys in the front row, because you don't need to. But amazing work, Amit and Bits and the whole team, and salutations to all the leaders.